All right, so it is October 19th, 2020. I think it's still 2020. We haven't had the season finale of 2020 yet, so December is when the White Walkers come and take over the Earth. We just haven't gotten there yet. But it is December 19th, 2020, and it is Monday morning, and we are going to talk about cerebrovascular accidents, otherwise known as strokes. And sometimes I hear when I teach this lesson, the students will say, Mr. Keever, I think I'm having a stroke from this lesson. That is completely normal. This is probably farther in depth than you've ever had with strokes. So, pace yourself when you actually have to go back and learn this. I'll talk about what you need to know for your boards, kind of what's important to know, what's good to know, and then what's kind of an FYI that, it's good to it's nice to know it, but it's not something definitely hardcore for your boards that you need to have. So my slide has a black square. Oh, that's probably because I'm only using one screen. I apologize. So I'll turn off my video and I'll turn the video on when I actually demonstrate something, because that'll take care of that black square. If the problem is I'm only using one screen right now, and that's kind of blocking some things here. So let me turn off my video. Does that take care of one of the black squares? Okay, and I'm going to close the chat and I'll open it when I have questions. So it'll alert me. So if I close this, does that give you more of the screen and less of a black square? Okay, cool. I'll just close it and open it as I see questions then. That's all the most I can close off. So the only thing I can leave, the only thing that'll be blocked off is kind of this top bar for me. Unfortunately, that's a change they made to Zoom on Friday, and it's in a they're going to patch it out tomorrow from what they said. So I apologize. It's one of those things. They made changes to the software. I can't really do much about that. All right. So cerebrovascular accident, or CVAs. It's a sudden loss of neurological function caused by the interruption of blood flow to the brain that persists for at least 24 hours. This is key to understanding CVAs. So it's a loss of blood flow to some area of the brain, and it can be a minor area, it can be a major area, but the persistent symptoms have to last longer than 24 hours. We're going to talk about this. If it's less than 24 hours, it's a transient ischemic attack, meaning it is a transient, it comes and goes, ischemic, cut off of blood flow, attack where the blood kind of gets cut off. I don't know why they don't call it transient ischemic accident to kind of match them up, but this is the medical field and we can't do anything logically. So CVA, you have to have a loss of blood flow, and you have to also have a persistent neurological symptom that lasts longer than 24 hours. Now, this can occur a couple different ways, right? And we're going to talk about a couple different ways. And this can occur at any age. You can have a stroke in utero. You can have a stroke when you're 94 years old. So strokes are one of those disorders, the neurological disorders, that can happen to you anytime in life. There's no way that you can really, predict when and where it's going to happen. Now, there's some modifications you can make that can kind of keep you from having strokes, but there's not a way that you can necessarily avoid them 100%. So ischemics are the most common stroke, right? Ischemic meaning blockage. So the blood vessel gets blocked by something. It can be by a blood clot. It can be by fatty plaques. It can be, by some foreign body that gets in your body. When you think about it, a myocardial infarction, right, is really nothing more than a stroke of your heart. And it's just an ischemic blood flow cutoff of your heart, right? Same thing, kind of idea here. So some part of your brain will get blocked off. That's an ischemic. That is the most common. So 80% of strokes are about ischemics. Hemorrhagic strokes occur for the last 20%. Now, they also account for the most deaths from stroke, and that makes sense. Hemorrhagic means bleeding, right? And honestly, if you encounter a hemorrhagic stroke in the hospital or in rehab, it's pretty rare because most of them are going to die from the stroke. If you look at it, mortality rate is as high as 38% status post 1 month out. So at about a month out, 40% of the people die from hemorrhagic stroke. And when you think about it, that kind of makes sense too, because when your brain bleeds into itself, you're not going to have a good result. because you're going to increase intracranial pressure and you're going to have more neural pruning, and it's going to do some bad things to the brain, is basically what I'm saying. So the incidence rate is 1.25 times greater for men than women under the age of 85. Once you get above 85, it's 50-50. At that point, it's an equal opportunity attacker. But up to 85, it's about 1.5 times greater for men. And there's all kinds of reasons for this, the shape of the man's heart versus the female's heart, stuff like that, that causes this. But, you know, up to age 85, men more likely than women. So again, for your boards, that's the most important thing to know. They're not going to typically ask you a question about the percentage, you know, what's the incidence rate from men to women? No, but they might ask you if strokes occur more frequently in men than women. In that generalized question, yes, strokes occur more frequently in men than women. Strokes are the fourth leading cause of death in the United States and is the most common cause of disability in the United States. Because typically when you have a stroke, bad things are going to follow it. And that will either lead to you, unfortunately, dying, or it'll lead to you having some major problems with the rest of your life and functioning. Now, again, the other downside to strokes are if you have one stroke, whether it's hemorrhagic or whether it's ischemic, you are likely to have subsequent strokes later in life. Even if you have a young stroke, it's one of those that you're going to have to protect for the rest of your life so that you don't have another one later in life. So what kind of stuff can cause this? So atherosclerosis is probably the most common cause of strokes, right? So remember, atherosclerosis is a form of arteriosclerosis. So arteriosclerosis, hardening of the lumen of the veins, or the arteries, right? So arteriosclerosis, hardening of the arteries. Atherosclerosis, now because the arteries are hard and they aren't squeezing as well, plaque buildups start occurring. And those plaque buildups can be from cholesterol, they can be from plaques, actually from plasma and gunk, lipids, fibrin complexes, complex carbs, calcium deposits, all of that will slowly build up on those arterial walls. And as that builds up, it's going to close off the volume of that artery until eventually it'll basically become a gunky block, right? It leads to that narrowing of the blood vessels. So that's one of the things that can cause it. Arteriovenous malformation and decreased integrity of the vascular system. So arteriovenous malformation, literally meaning artery vein bad forming, right? So that's where you get blood vessels that maybe are either regrowing in an area, repairing an area, you know, just pruning and kind of cleaning up an area, because our body goes through constant new growth at all times, right? We have neoplasms occurring at all times, right? We have healthy neoplasms occurring where we're growing new blood vessels, new muscle, new tissue, right? And then we have unhealthy neoplasms where we get into the whole cancer idea. But in this case, we get an arteriovenous malformation where maybe something in the circle of Willis doesn't grow the way it should grow, and you have an abnormal growth of blood vessels. That can also lead to a stroke. You can also have decreased vascular integrity, meaning that the walls or the lumens of that artery just don't have the same patency that other arteries have. And what I mean by that is they're not as strong. A lot of times they'll get weak spots in them and they'll get aneurysms. We're going to talk about aneurysms in a second. So two problems you can think about when we have this is we can either have that the arteries are closing off or they're becoming so weak that they're stretching. So this is kind of the formation of atherosclerosis. That's a good placement of the actual writing there. Good job, Mr. McKeever, right? So here's what we have. So we have some arteriosclerosis occurring out here in the artery walls, right? So those artery walls are starting to get harder. And then the plaques are coming in. So the plaques start building up. I'm gonna change the color because yellow is not a good idea. Red's not the best idea either. Let's go with brown, that'll work. So here we have our arteriosclerosis, the hardening of those walls. So now the walls don't expand as much. Because they don't expand as much, stuff comes down and kind of clumps up. Oh, I'm gonna hang out here. And once they start clumping up, some other buddies come in. Hey, I'm gonna hang out too. And those clumps just keep building up until we end up with this whole kind of this plaque here, right? And this just kind of blocks off. Well, then we get other stuff kind of coming back here that starts blocking up even more, right? And so then as it comes down, it's going to shorten and shorten the amount of blood that can get through until we get down to about a 15% level. When we get down to that 15% level, that's when things start getting bad. Under 15%, usually we can function pretty well. And that's pretty, honestly, it's pretty amazing when you think about it in the human body, is that all the way up till we get to 85% blockage, we can function pretty well. We get to 85% blockage, that's where we end up with some problems. And so, you know, you get this hardening going on, and then somewhere up in your body, you throw a blood clot, right? Maybe you got a DVT and it started your leg. Well, now that blood clot comes in and hits this really narrow joint. Well, there's a narrow joint there. It can't get through. It's going to kind of get stuck too. And then it will harden down and it'll block all blood flow to that area. So anything down here in the body is now not getting blood and is going ischemic. That's kind of looking at atherosclerosis, right? So here we have aneurysms, and this is important to understand. So this would be one that you'd want to kind of do this. That's a really bad star. Let's try that again. There we go. That looks better, sort of. Kind of looks like a Blair Witch thing. Aneurysms are important to understand the different types. So the two main types of aneurysms are saccular aneurysms and fusiform aneurysms. Saccular aneurysms form a sac. Fusiform are the ones where the walls themselves kind of spread out. Let me move this out of the way here and put it over here. Hopefully that'll work. So this is where the whole wall itself is spread out. Typically, when we're dealing with these problems, these are going to be a little bit worse than this. Because this is, when you think about physics, this is force spread over a greater area, right? Whereas here, we have a very small area where force is now spread across. So saccular, while they're bad aneurysm, or fusiform, while they're bad aneurysms, yes, the saccular ones are worse, because what's happened in the saccular one is literally this little piece of wall here has now stretched and become a balloon. And we know from being little kids, when those balloons get filled up and filled up and filled up and filled up, eventually they're going to pop, and ruptured aneurysms can occur from that. That doesn't mean that fusiforms can't pop. They can. They're just a little bit less likely to pop. The saccular aneurysms are a little bit more common to pop. So what can be some risk factors for a stroke? Well, let's talk about the two different types of risk factors. So we got a question here. Yeah, ruptures can happen in both, Jerry. You're exactly correct. It's more likely to happen in saccular. Honestly, if you have a fusiform that ruptures, it's usually more likely to be worse because it's a large area of the blood vessel that'll end up with that rupture. But sacculars are the most common to rupture themselves. So let's talk about risk factors. We have two different types of risk factors when we're talking about any disease, right? We have modifiable risks and we have non-modifiable risks. Non-modifiable risk would be stuff that we can't change, like our age, our sex, or our gender, right? And again, not assuming anyone's gender, just the actual physiological gender that you were born with can affect, you know, if you have a stroke or not. This includes people that maybe have had, if you look at, because I was curious, I looked last night, there's not any hardcore studies on it. There was a brief study out of Boston about it, but people that have gender reassignment surgeries, does the risk for strokes and that go down? No, it doesn't. The risk of stroke are still associated with the born gender that they have. So if you're born male and you transition to female, you still have the same risks as a normal biological male for having a stroke. So, you know, this does go a little bit into that whole biological versus neurological gender, right? But for this case, biological gender is unchangeable. It's what you're born with. You're either XX or XY. I guess you could be XXY, but we're not talking about that right now. So we'll talk age, we'll talk sex, heredity. You can't change your genes right now. Now, granted, you can change the genes that you're wearing, but you can't change the genes that are inside your body. Those don't change. They're what you're born with. They're non-modifiable. So most of the time, the problem for strokes are these modifiable risk factors, the things that you can change, right? Smoking is a major, 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 major risk factor for having a stroke. That includes vaping. Vaping does not get you out of it because the main problem with the actual stroke factor is not the method that you're taking in, it's the nicotine. The nicotine can lead to some bad things. Hypertension, right? And that also ties into obesity and diet, right? But hypertension is a major risk factor. Heart disease. If you have heart problems, it's likely that you're going to potentially set yourself up for brain problems. Diabetes, right? Your activity level. The more active you are, the less likely you are to have a stroke. If you have AFib, atrial fibrillation, your risk factors for having a stroke are dramatically higher if the heart is not working the way it should. And that kind of makes sense, right? If your atrium is kind of quivering rather than doing a nice dump into the ventricles, that gives time for blood to kind of sit for a longer period of time. And we know that if blood sits for periods of time, it likes to make clots. And that's why a lot of patients with atrial fibrillation will have problems with blood clots. Previous transient ischemic attacks, that can also lead to further strokes down the line. And then alcohol consumption. So the studies are still out on this, right? That says that alcohol in moderation can sometimes help with strokes. And moderation is not the place you drink at when you're drinking alcohol. Moderation meaning, a glass or two of wine here or there. Red wine and the tannins in red wine have been shown to have some positive effect on folks that have some of the other risk factors at preventing stroke. That doesn't mean, and that does not give you license that, Mr. Kiefer said that I should start drinking so that I can stop having a stroke. That's not what I'm saying, right? Please don't think that. What I'm saying is that alcohol has some kind of a weird effect. And if you look at the way alcohol affects the body, at certain peak points, it does do some good things for your body. It causes some relaxation, some depression, but also then you get past that and you start getting into the higher levels of alcohol, and that can cause negative effects. So alcohol is both, I wouldn't say good thing's not the term for it, but it can do beneficial things to the body, but can also then do negative effects, right? We use alcohol as an antiseptic, so it does do beneficial things. So talking about some less common symptoms, right? Sudden nausea, fever, and vomiting are distinguished from a virus by speed of onset. So if you are, at home, you're not sick to begin with, but all of a sudden you get a random fever with nausea and vomiting, that can be problematic. That can also be a sign of a heart attack as well. So that can be a symbol that you're having some vascular issues. It can also be a sign of food poisoning. So you've got to be careful. Brief loss of consciousness for a period of decreased consciousness, fainting, confusion, coma, all of that can be, signs for a stroke. So we have the stroke warning signs over here from the American Heart Association. But, when we're talking about strokes and we're talking about understanding strokes, what we need to understand is this acronym, FAST. This is the screening we use for strokes in the hospital setting, right? So that F stands for face. Green doesn't look good. Let's get rid of that one. It's a very light green. I don't like it. Let's go with the dark green. There we go. That looks a little easier to read. So when I say face, if yours or your patient's face has differentiating signs on either side of the face, meaning that one side of the face is showing weakness, is showing drooping, that can be a sign of a stroke. A stands for arms. You're going to have your patient, or if it's you that you're worried about having a stroke, raise your arms above their head or as far as they can raise it, right? Because if they get shoulder problems, they may not be able to raise their arms above their head. So raise your arms up, Mr. and Mrs. Jones. What you're looking for is one of the arms to either be slower than the other or having a lag effect where one arm comes up nice and smoothly, the other arm takes a little bit of time. That would be a sign that they could be having problems. Speech, have them talk to you or listen to them talk to you. If they're starting to have slurred speech, or if they're starting to have nonsensical words, or they're starting to show some signs of either Broca's or Wernicke's aphasia, that can be a sign of a stroke. And then time, and I often say time times 2. Now, this is not necessarily a hard thing, a hard rule, but time is the important thing. Because time, if you've had these other 3 signs, it's time to call a code or call 911. The other thing is it's time to note when the first symptoms occurred, because the medications that can be given for an ischemic stroke have a certain window of efficacy. And if you don't get the patient the medication within that window, it may not be as good. It may not function as well. They may not have as good of a recovery. So it's important to understand that time means it's time to get them help. It's also time to note when the symptoms occur. So FAST is an important screening. You need to know that for your boards because they're going to ask you about it. So heart association, sudden numbness or weakness in the face, we talked about it. Sudden confusion, there's that speech. Sudden trouble seeing in one or both eyes. Sudden trouble walking, dizziness, loss of consciousness or coordination, or loss of balance. Sudden and severe headache, right? This is the major thing you want to pay attention to if you're working with a patient that has a stroke. You're watching them for unknown or new cephalgia, right? So new headache. If they have a new onset of a headache, especially a new onset of severe headache, that is a wave off. You are not going to treat that patient at that time. That is time to go get the nurse, and it may be time to call a code if they have a headache that bad. It is important to call 911 or get them emergency help as soon as possible. The sooner they can start receiving emergent care, the more likely the patient is to survive. And again, we talked about this. Also note the time when first symptoms appeared. It's important. It says here, if given within 3 hours to start of symptoms, clot-busting drugs called plasmagen activator, tissue plasmagenic activator, may reduce long-term disability for the most common types of stroke. So you do need to know the medication. The most common medication for a stroke is this medication called tissue plasmagenic activator. Often you'll see it abbreviated as TPA. It should be given within the first 3 hours of a stroke. Now, most doctors will tell you it's most effective within the first 2 hours. It is not an anticoagulant in the same mindset as warfarin or heparin, right? Those prevent clots from forming. TPA is a clot buster, meaning it is going to go in and break down all the fibrogen clots in the body, and it is non-specific. So it's not only going to break up clots that are in the brain, maybe causing a stroke, but it's going to break up clots anywhere, right? They're going to have similar reactions to having an anticoagulant. So they're going to bruise easy. It's easy to get cuts, stuff like that. The downside to this is with an anticoagulant, bleeding, if they get a new wound, will take a little bit longer to clot, but it will eventually clot. If the patient has a TPA, there's a likelihood that they will not clot if they get a cut while that TPA is still in the system. So understand that that medication is a pretty potent drug that they're giving them. It is stopping clotting, not only stopping the clotting factors of the whole body, but it's also breaking down clots. So time is important. Calling 911. The more time that it takes, the more the brain that is going to die. Even if the symptoms subside or not painful, even if you're having a transient ischemic attack, it's important to get seen by a medical professional. And we said about medication, and again, for ischemic strokes only are most effective within the first 3 hours. And the doctor must differentiate between them, what type of strokes they're having, and also what medications are on, because certain medications are contraindicated, with TPA, right? That TPA that I just talked about, tissue plasmagenic activator. The other thing is, if the patient is having a hemorrhagic event where they're bleeding in their brain, and the doc doesn't diagnose them as a hemorrhagic stroke and instead thinks they're a ischemic stroke, think about that for a second. You're bleeding in your brain, and we give you now a drug that basically is a super clot buster that breaks down all the clotting factors of your blood. You're more likely to bleed worse and obviously die more frequently from that. So this is a really, really tight window of opportunity for these docs. They don't exactly, this is not we can observe it for a while and see what happens. That's not the way this is going to work. It's a really tight window of opportunity for the doc to provide them with that emergent care. And if we don't keep an eye on it, it can be problematic. So intracranial pressure, right? So now we're talking about more almost hemorrhagic strokes, but ICP can go up also with the block ischemic strokes. But let's think about it. So now I've got a bleed into my brain. As that blood is starting to flow in, right? As that blood is flowing into my brain, well, now I've got a problem because the cranium is only so large. And that blood's going to start taking up space. What's going to happen is the brain is going to slowly get squished inward. The body is going to realize, hey, we've got a problem here. And if we don't deal with this problem, we're going to have bigger problems. So a lot of times, decreased level of consciousness will occur, stupor and coma. The body's going to put itself into a state where it's protecting itself. It's also going to start pruning off exterior parts of the brain, right? So those most outer layers, it's going to start pruning off to create a pressure gradient in the brain to allow for room to expand. You're going to have widened pulse pressure. So when you hear widened pulse pressure, that is the difference between systolic and diastolic. If we have 120 over 80, the normal widened or the normal pulse pressure difference is about 40 millimeters of mercury. In a patient that's having a stroke, it's not uncommon for you to see blood pressures of 200, 300 over 80. That is definitely a widened pulse pressure. You can have increased heart rate, irregular respirations, and these things called Shane-Stokes respirations, right, where the patient's literally gasping for air. That's usually not a good sign, right? That means that the brainstem is being compromised. Vomiting, and oftentimes, cranial nerve 3 signs where the pupils themselves are not responding to any light. Those are all signs that pressure in the brain is going up. If pressure in the brain is going up, that's a bad thing. It means that the brain is dying. And the more the brain that dies, the less you are going to function coming out of the stroke. So the severity and symptoms of stroke are really dependent on a couple of things. The location of the lesion. If you get a brainstem stroke, it is going to be more lethal to you than if you get a stroke in Broca's area. The size of the damage. How much brain died? If you get a little stroke and a little part of the brain dies, not as bad. Can I go back super quick? I can go back super quick. Sure. I went back super quick. What's up? Okay, cool. So again, symptoms and severity of a stroke are dependent upon the location where that's happening. The worst type of strokes you can have are brainstem strokes. And that's got to make sense to all of you without even really having a total knowledge of how the brain fully works and everything like that maybe a neurologist has. But the brainstem is where all life happens. If you get a stroke there, that's going to be problematic. The size of the damage is going to be important as well. If you have a little itsy bitsy area of stroke, not going to have as many long-term effects as a large chunk of the brain being dead. The nature and function of the structures involved. Again, that kind of goes back to the location as well. If you have a stroke in the posterior cortex of the brain, right in that area of vision, while bad, you can live without vision. If you have a stroke in the pons or a pontine stroke, that's going to be a lot worse and you may not live through it. And then the availability of collateral blood flow. Can blood get to the area from a different source? If you have increased chance for blood to kind of go from another route, right? So if you have the brief circle of Willis here, right? And you have a cutoff of blood over here, if blood can still kind of flow around this side and still get to that area, you'll have a greater chance of having function versus dysfunction. We're going to talk about that with the circle of Willis in a little bit. So a couple key definitions here when we're talking about strokes. IVH, intraventricular hemorrhage. This is a rupture of a cerebral vessel and bleeding into the brain, specifically into the ventricles. Remember, the ventricles are supposed to be filled with CSF, not with blood. So the more blood that flows in that area means less CSF in that area. Or it can also mean that the actual ventricles themselves are going to start pressing out on the brain around them. That can be a problem. Cerebral hemorrhage occurs in small blood vessels weakened by atherosclerosis and produces an aneurysm potentially, right? Cerebral hemorrhage, a hemorrhage in the cerebrum. Subarachnoid hemorrhage. This is not as bad as some of the other strokes you can have, but it still can cause some major problems because of that intracranial pressure. This is where you get bleeding into that subarachnoid space, right? So the area below the arachnid matter. So remember, we have our 3 layers of our meninges, right? We have our dura, we have our arachnoid, and then we have our pia, right? Our hard mother, our spider web, and then our soft mother that protect our brain. In this space here between the arachnoid and the pia mater, there is a space called the subarachnoid space. There are some blood vessels in there. There are some vessels that bring cerebrospinal fluid, stuff like that. If you have a bleed into that area, that can cause problems because it is going to push down on the brain, and pushing down on the brain, not good things. Arteriovenous malformation is a congenital defect characterized by tortuous tangle. I love this. So we're using alliteration here. Tortuous tangle of arteries and veins with agenesis of interposing capillary systems, right? So this would be, you know, I'm supposed to have a blood vessel that looks like this and maybe forks off into 2 separate vessels. If you have an arteriovenous malformation, you might have something where the veins or the arteries kind of go all over the place, and they don't go necessarily to their targeted tissue. Up here's my targeted tissue, right? So that's when the blood vessels are not growing the way they should be. And a lot of times that's going to be just a congenital defect. Honestly, if you look at most people, somewhere in our body, most people have an arteriovenous malformation and it never affects them. Because it's just something that happens, body takes care of it. Unless, you know, this is severely in the brain, and then it can cause lack of blood flow to areas of the brain. Cerebral edema is produced by ischemic strokes causing tissue necrosis and rupture of cell membranes. So again, as that stroke causes tissues to die, oh, we got a question. It is when the veins can become zigzagged. You're exactly correct, right? The zigzag, instead of being nice, smooth veins and arteries where they flow at a nice, even rate, if they come zigzag and stuff like that, that's going to increase the pressure in those veins and arteries for sure. So that would be an arteriovenous malformation as well. You're exactly correct, Renee. Great observation. But cerebral edema, so let's think about the brain here for a second, right? So I'm going to do my worst cranial vault drawing here, right? So here's my brain. I've got my brain and my brainstem inside my skull. If I get some focal damage up here, right, what's going to happen is that area is going to die off. In come all my nerve cells, because they're going to come in and they're going to start pruning off this area and protecting all of the surrounding tissue from that dead area. One of the byproducts of that is increased fluid in that area. So edema, swelling happens in that area. We know that swelling is a normal part of the inflammation process, even in the brain, right? The problem with cerebral edema is when we get swelling in the brain, it pushes on other areas of the brain. So it's very common that even if you have a small area of the brain that gets hurt, it's very, very common for other areas of the brain to die off because of the pressure caused by swelling. And that can lead to more permanent disability, right? So it's not always the case where if the blood vessel, you know, if you get a stroke in the anterior portion of the brain, that's the only place you have symptoms. You may actually have some posterior portions of the brain symptoms. You may have some vision problems because your body has had a lot of pressure on that brain. Transient ischemic attack, right? Transient ischemic attack is a temporary interruption of blood supply to the brain that lasts a few minutes or hours, but the symptoms typically don't last longer than 24 hours. There's usually not a residual evidence of brain damage or reduced neurological function. These are typically considered milder, but if you ask a patient that's having a transient ischemic attack, they're anything from mild. These are not something they want to have, right? And it may be a precursor or precurse a larger event. So you may have multiple little TIAs building up to one major CVA. That's where it's really important if you start having TIAs to change those modifiable risk factors to prevent you at least from having a major CVA down the road. A major stroke is a stable stroke, that stable meaning that they don't decline, but it usually has pretty severe impairments. So this is where the stroke, it causes some major functional deficits that don't return. And there can be, when you think about the way the brain works, those functional deficits can be just about anything. It can be speech, it can be sight, it can be hearing, it can be, functional walking, functional balance. A deteriorating stroke, it's exactly like it sounds. So the patient comes in and they've had a stroke, they have certain symptoms, but as the time progresses that they're in the hospital, they get worse and worse and worse and worse, and very rarely do they get better. Again, these type of strokes, the deteriorating strokes, are less likely to have good outcomes. That can be really bad for these people because the deteriorating stroke means they're just keeping getting worse. A lot of times this can be caused by that cerebral edema, or it can also just be caused by having a small bleed that the doctors can't find, right? A young stroke is considered a stroke in anyone under 45. So basically what they're saying is anyone over 45, it's completely normal to potentially get a stroke. But under 45, it's kind of rare. So they call that a young stroke. So it's good to know that until you're 45, you're still considered young, right? But I often find those people that have young strokes are the ones that have kind of, I don't say the worst outcomes, the worst outlooks would be a better term for it. Because it's a really traumatic event to have a stroke. And if you're young and you have a stroke, it often makes you question why you've had this stroke. How's this happening to me? And it can lead to other neurological, psychological dysfunctions. So here's talking about the circle of Willis. So the circle of Willis is a clinically important anastomosis at the base of the brain. Anastomosis is a really big word, right? Anastomosis. It's one of my favorite words too. What it means is a multi-feed system. So, whoops, let's change colors here. What you talking about, Willis? You're exactly right. What you talking about, Willis? The circle of what you talking about. Multi-pass. No, not multi-pass. Multi-feed system. So if you know anything about cars, the circle of Willis is much like a fuel injection system because there are multiple spaces that blood can get to the brain. So when it says multi-feed, it means there are, multiple processes of allowing blood to get to the brain. So circle of Willis sits here at the nice base of the brain down here. Here's the top part of it. Here's the back part of it. It has these two main feeds right here, which are the internal carotids. Those are the primary source of blood to the circle of Willis. But also back here, we have our vertebral arteries coming up from the spine. They also provide blood to the circle of Willis. So if I lose one of these internal carotids because of maybe a blockage, maybe I get a cut, I don't know, maybe I get trauma to that area, I'm still going to get blood to the brain because there's blood coming in this artery and there's blood coming in these arteries to provide collateral blood flow. This is why it's kind of important. It's a multi-feed system to the whole brain. If I get a stroke right there, right? In any other case, this whole area up here is screwed. But because of the circle of Willis, if I get a block there, the blood can still come all the way around here and still go out that way. So it is a multi-feed system. It allows the brain to have multiple choices for blood flow. To me, this is amazing because when I think about this, I'm like, wow, when the brain was developed or was being formed, we developed this really, really technical blood flow system that protects the brain from having lack of blood. That just amazes me. So in cases of obstruction, the collateral flow can help preserve blood supply in some cases. Now, it doesn't always happen, right? If you get a blood clot in a large enough area, especially if you get something back here in the basilar artery or in the pontines, that can be really problematic. You get a blood clot in the internal carotids or middle cerebral arteries. Definitely problematic, right? If you have a blood clot up here, once you're outside of the circle of Willis, well, you're not going to get collateral blood flow at that point. But if you look, most of the areas of the brain have multiple feeds as well for filling their blood flow needs. So in a way, the brain is designed as a fail-safe technique so that it always has blood flow. So how do we diagnose a stroke? Well, we can do a biomarker arrays panel, meaning they're going to take blood and they're going to run that blood through a whole series of biomarker arrays to look to see what we're looking at. Do we have increased clotting factor? What does our INR look like, right? What's our fibrin versus fibrinogen parts of the blood? We can do an MRI of the brain, right? MRIs will give us some information of the brain. An X-ray is not going to show anything. The X-ray is just going to show if the skull is intact, but MRIs will at least give us some soft tissue. We can do pulse Doppler ultrasound, very similar to what we do with the baby when we're pregnant to see if baby is growing or not growing. You can do that along the carotid arteries. You can't do it when you get up to the brain. The pulse Doppler won't necessarily always penetrate the skull, but if it's something that's happening in the carotids or the blood flow feeds like the vertebral arteries leading up there, you definitely can use pulse Doppler ultrasound. We can do a CT scan, right? We can do magnetic resonance angiography. So now, right, instead of just looking at the soft tissues, we're now going to inject a reactive dye into the arteries. And that reactive dye is going to light up on the magnetic resonance. And we can actually look if there's somewhere where the blood's not getting to. We can do an arteriography where we actually go up into those blood vessels and kind of look at it. And we can do digital subtraction angiographies where we're looking at and we kind of break down the blood flow going to the brain and pull out the ones that are still functioning, right? So in our actual medical diagnosis, or not diagnosis is not the term I want to talk about, but we can look at medical imaging and say, okay, well, that blood vessel is functioning fine, pull that out of the list. Well, this blood vessel is functioning fine, pull that out of the list until we get down to likely culprits that are causing the stroke. And this can be important because some of those areas, we have maybe a severe ischemic event, or if we have a hemorrhagic event, they may be able to do surgery to stop the bleed. Not always, right? If it's buried deep into the brain, they're not necessarily going to be able to do surgery to repair or lessen the effects of that bleed. And that can be problematic. And again, if you have a hemorrhagic stroke, there's a good likelihood you're not going to make it. So before I get into these, I know it's not been a complete hour yet, but these are where we start getting important. So let's take a break here. Get up, stretch your legs out a little bit, get some blood flow going. Ha, 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 ha. And we'll come back and we'll start talking about the different types of stroke because I want you guys to kind of be a little bit focused when we talk about these because these are really important. So let's go ahead. I'm going to pause sharing, stop sharing. So let's take a 10-minute break here and then we'll come back in 10 minutes and continue this at that slide point. But let's take a break here because this, again, this is an important part. So go get some caffeine, go get a little bit of a stretch on, go to the restroom. And we'll come back and we'll talk about this exciting topic in a few minutes. So take a break real quick, come back in 10. So we're back from our break here. So we're going to start talking about the different type of syndromes that occur with strokes. And these syndromes are typically going to be in response to the blood vessel affected. Now, these are the most common types. These aren't all of the types. These are the most common ones you're going to encounter in the acute care setting, outpatient setting, everything like that. It's really common, and I try to gauge these based upon which ones are the most common to the lesser common as we went through. So the ACA is kind of one of the most common ones we're going to deal with, the anterior cerebral artery. So the anterior front part of the cerebral, right, going to the cerebrum artery. If you have an anterior cerebral artery stroke, you are likely to have contralateral. So if I have a stroke on my right side of my my right ACA, I'm likely to have left-sided effect. Contralateral hemiparesis, partial paralysis, and hemisensory loss, typically greater in the lower extremities than the upper extremities. So again, you're going to have more likely to have opposite side sensory and movement loss more present in the lower extremities than the upper extremities. It's important to understand that is the anterior cerebral artery. We're going to talk about the middle in a little bit. The middle is reversed. So anterior, lower, greater than upper. They're typically going to have urinary incontinence, and they're typically going to have apraxia, so problems with motor planning, right? And table 15.1 on page 651 has a ton of other kinds of losses that go along with this. But the most important ones are going to be that contralateral hemiparesis, that the lower extremities are greater than the upper extremities, urinary incontinence, and apraxia. Now, when I talk about these, one of the things I want to preface, you may see an anterior cerebral artery stroke that is different. Well, that's unfortunately the way the brain works. Sometimes people just are wired a little differently. But for the most part, this is your common way that your patients are going to present. So now we go from the anterior cerebral artery, we're now going to the middle cerebral artery. So going to the middle of the cerebrum. You're still going to have opposite side hemiparesis and hemisensory loss. But in this case, the face and upper extremities are going to be more affected than the lower extremities. In middle cerebral artery syndrome, oftentimes you're going to get unilateral neglect and agnosia. So unilateral neglect meaning you're going to start ignoring those parts that aren't functioning, especially if you've lost use of an arm. Again, you can still lose function of the lower extremities, just less common in middle cerebral artery syndrome. So you're going to start basically disavowing that those are part of your body. Just because they're not functioning, you don't have sensation in them. So you're just going to say, hey, that's not my arm. Hey, that's not my leg. And again, agnosia is that inability to recognize objects will come along with it. You'll often have either Broca's or Wernicke's aphasia or problems with speech. And it's going to depend upon where that stroke occurs along that middle cerebral artery, which you're going to get, right? Broca's being that broken speech, and Wernicke's being fluent aphasia or receptive aphasia, where they either have problems getting out what they mean to mean, you know, instead of saying, I'm getting up, my purple dragon's flying out of my butt. That's not what they wanted to say. They know that's not what they wanted to say, but that's what came out. So it's really difficult for patients that have Wernicke's, or they'll have receptive aphasia where they just aren't getting what you're saying. And you may have to use different types of communication techniques with them. They usually are going to have contralateral hominis heminopsia or heminopia, right? Where they have part of their vision on one side being affected. And again, it's going to be contralateral. So if it's a right-sided middle cerebral artery, they're typically going to have left eye problems. In a general sense, when you have a stroke, it is typically going to affect the contralateral side to where it's being stroked out at. So if I have a right-sided stroke, my left side is going to be affected. If I have a left-sided stroke, my right side is going to be affected. Doesn't always necessarily have to happen that way, but it's the most common way it presents. When you get a question on your boards and they say left-sided CVA, they're talking about the part of the brain that's affected, not the part of the body. So if they say left CVA, that means the blowout is in the left portion of the brain. You have to understand that it's the right portion or the right part of the body that's being affected. And that can be really useful because you may go down into your answers. And if it's talking about a left CVA and you go down to your answers and there are 3 answers that are talking about the left side of the body, you can eliminate all those answers because you know that if it's a left-sided stroke, it's typically going to be right side effect. Posterior cerebral artery syndrome. Well, that makes sense. We're now going to the back side of the brain. So our most common problem is going to be vision. So they're going to have visual field defects. They're going to have visual agnosias, right? The inability to recognize stuff by sight. Prosopagnosia is really common, the inability to recognize faces. There are going to be some other problems. There are going to be some balance issues and stuff like that that go along with this as well. But that makes sense because part of our balance system, right? Part of that inner ability to maintain balance and maintain that homeostasis of balance comes from being able to see things. And if we can't see things, we're going to have balance issues. Internal carotid. Well, that makes sense. It says it's going to be a massive infarct. Well, you got to think about that. If you've never dissected a human cadaver, or you've never dissected even a cat or a pig or something like that in anatomy class before, the internal carotids are very, very large arteries. They're pretty chunky. Now, not as big as something like the jugular veins and stuff like that, but they're still pretty beefy. So if you get a stroke in the internal carotid, it's going to be a massive infarct. And depending upon the side that's affected, again, typically you're going to have contralateral side loss. And it's typically going to push blood clots into other parts of the brain as well, because if that clot gets blocked off in the internal carotid, oftentimes more of it's going to travel. Lacunar infarcts. So lacunar is when we're having areas around the brain that have infarcts. This is really specific presentation based upon location. If you have a small lacunar infarct in, say, your auditory cortex, well, then only the auditory cortex is going to be affected because it's such a small infarct. It's a very small area that dies off. That's kind of the idea of a lacunar area. If you have it maybe in Broca's area, and that's the only area that it gets affected, well, that's going to be the specific presentation. This is talking a lot smaller, a lot finer type strokes. That's supposed to be vertebrobasilar. I don't know how I misspelled that. That's what I get for doing this late at night. Vertebrobasilar artery syndrome. Yeah, I don't know what that says. Verobro, man. Vertebrobasilar artery syndrome, right? So this is where the basilar artery, which is at the base of the brain, is going to be affected. It's really common for them to have locked-in syndrome, Wallenberg syndrome, Horner syndrome. But the main thing you need to know about this is if the basilar artery is affected, most life functions are going to be affected. The reason the patient is going to go into these locked-in or these weird syndromes is the body is shutting down. That basilar artery, right? We go back here to that circle of Willis, right? So this is my big fat basilar artery back here, right? That is sitting here at the brainstem, and that's providing all this blood flow to the brainstem. If I get a stroke there, bad things are going to happen. The other thing that's going to happen is that's literally going to cut off a good chunk of my blood flow because I've now lost my 2 vertebral arteries from it. That's going to cause symptoms in other parts of the body. And the brain is basically going to say, I can't function right now, and is going to try to lock down in order to prevent them from getting further symptoms. So some primary effects and problems with strokes, right? Sensation is impaired, but it's rarely absent on the same side. So they may have, again, contralateral side, absolutely, they're going to lose sensation, but they may have some residual absent sensation on the same side as a stroke, but not as bad as the contralateral side. They'll lose proprioception, superficial touch, pain, and temperature sensation on that contralateral side. Hemorrhagic or ischemic strokes can result in severe headaches and or neck and or face pain. Well, that makes sense. The body's going to try to transfer that pain somewhere that we're paying attention. If the stroke may occur in the area near the thalamus or the feed to the thalamus, they may end up with what's called thalamic pain syndrome or DeJean-Rousey syndrome. This is where they get a constant severe burning pain with intermittent sharp pains brought on by exaggerated response to stimuli. We talked about this dysesthesia before, right? So this is where just sitting down, the feeling of the chair or the bed or whatever under their bottom causes them pain, even though they shouldn't be having pain from that. Altered coordination is really common, right? Sensory ataxia, the inability to carry out that plan due to proprioceptive losses, due to balance losses with cerebral lesions and cerebellar ataxia, right? So if you have a cerebellum issue, a lot of times it's going to cause all kinds of ataxic problems. The basal ganglia gets it. It's often that they're going to look very much like they either have Parkinson's or that they have myasthenia gravis. So they may have bradykinesia. They may have that chorea athetosis where they're doing really weird things. They may have hemiballismus, and hemiballismus is wide flailing motions of the upper extremities or lower extremities as they're moving. The more and the greater that hemisensory loss occurs, the greater the chances they are going to neglect that side of the body, right? They may have visual neglect as well, where they're starting to ignore that side of the eye, right? So we have to be thinking about that when we're working with them. Hominis hemenopsia is really common, a visual defect that affects about 26% of the patient. They may have forced gaze deviation, where the unopposed eye muscles, so the muscles that are actually functioning versus the muscles that aren't functioning, cause the eye to deviate in the direction of the intact musculature. This is going to be very common also with the rest of the body, which we're going to talk about when we have pusher syndrome. The body is always going to try to go towards the muscles that are working and away from the muscles that aren't working. So let's say that maybe for whatever reason, the stroke has affected the abductors of my eye, but my adductors, my adductors, are completely functional. If that's the case, my eye is going to drift towards adduction and almost drift towards that cross-eyed kind of appearance. Weakness is found in about 80 to 90% of all patients after a stroke, and it's a major factor in disability. Typically, when you get weakness, no matter which area it is, the weakness is going to be greater in the upper extremities than lower extremities and greater distally versus proximally. And again, this is going to be one of those where it's a case-by-case basis. So I can say that, and that's what the books are going to say. But then I get out in the field, and I've had somebody that their lower extremities have a greater weakness than their upper extremities. That's unfortunate side of working in neural side and the brain side is this is what the book says. It's not always what every patient presents like. Flaccidity. Almost every patient that comes out of a stroke, typically, due to the effects of cerebral shock and everything like that, the side that is affected is going to go flaccid immediately after the stroke. So if I have a right-sided stroke and my left side is affected, my left side is going to go flaccid immediately after because of that cerebral shock and the overall pain, right? The body likes to go into a shock factor when we've had a major injury. This can even occur in something like a car accident or something like that. You've always heard of patients going into shock. The brain does it too. The brain says, hey, something's not working here. So what I'm going to do is I'm going to shut down that part that's not working until I can figure out what's causing it. In the upper extremities, they're going to end up problems with scapular retractors, shoulder adductors, depressors, and internal rotators. The elbow flexors, forearm pronators are going to have problems, and the finger flexors and the wrist flexors are going to have problems. The neck and trunk, they're going to have increased flexion towards the hemiplegic side. So they're going to tend to flex towards that side that's having the stroke problems because the body's being kind of adjusted by the muscles that are still working. They will present with these abnormal synergy patterns. And we talked about this briefly with like Brunstrom's recovery patterns where we may use them initially, but we want to get those reintegrated. And again, synergy patterns are nothing more than regressions to previous things that have integrated in their bodies. A lot of times the pediatric reflexes. Patient may be unable to perform isolated movement of a limb segment without producing movements in the remainder of the limb. So they may not be able to perform fine tasks of the hand, but when you ask them to move their hand, they move their whole arm. After that initial period of spasticity, patients likely are to go into, or initial period of flaccidity, patients are likely to go into spasticity. So the arm is eventually going to contract up and go spastic, or the leg is eventually going to contract up and go spastic. So this is important to understand that as they progress, if they don't get care, everything is going to contract in towards the body. The lower extremities, pelvic retractors, the hip adductors, the internal rotators are more common. Hip and knee extensors, plantar flexors, supinators. We'll see that when we talk about that decerebrate versus decorticate posturing again. They'll also usually present with hyporeflexia at first, and then they'll go hyperreflexic when spasticity and synergies emerge, right? This is a sign of an upper motor neuron injury when patients become hyperreflexic. It's really common for Babinski to come back as a positive Babinski sign. Stretch reflexes are hyperactive, and they may get that clonus where they get that repetitive beating going on. They may get what's called clasp knife response, whereas if you stretch them out, the arm kind of snaps back and closes almost like a switchblade knife. And tonic reflexes, where problems start occurring and it just recurs and recurs and recurs. So we talked about praxias and taxias, right? So it's very common for these patients to get altered motor programming, where we have the inability to plan and execute coordinated movements because of motor apraxia, right? We talked about ideational versus ideomotor apraxia before. Ideational apraxia is where the patient cannot produce movement on command or automatically. Where ideomotor, the patient can move automatically, but not on command, right? So this would be the case where you ask the patient to stand up. And with either of these types of apraxias, they can't do it. But with ideomotor, you turn around and the patient stands up. And they didn't do it voluntarily. It just kind of occurred as a reflex of portion. That would be ideomotor. With ideational, they just can't do it, period. It's very common for them to get what's called ipsilateral pushing or contraversive pushing syndrome or pusher syndrome. This is the active pushing of the uninvolved extremities towards the hemiparetic side. So it results in lateral posture imbalance and tends to fall towards the hemiparetic side. And it makes sense because if I have one side that's weak, I'm going to kind of lean towards that side. I may overcompensate though and end up with pusher syndrome going the other way, where I know that I'm leaning to that side. And so I start pulling back to midline, but because I have nothing to resist that pull, I end up going to the opposite side. Balance is often disturbed in impairments with steadiness, symmetry, dynamic stability, right? Visual perceptual defects occur, right? Including disorders of the body, schema, image, right? They may get spatial relation problems, agnosias. They may say that I didn't have a stroke because they just aren't even seeing that side of their body as part of their body anymore. Cognition impairments are really common. Impairments in attention, alertness, orientation, memory, executive function, all that can be affected by this patient. We talked about confabulation before, right? So this is a patient that's had part of their brain kind of wiped out from the stroke and they don't remember everything. So they start filling in with facts. And a lot of times what will happen is, I've had it happen before, where a patient will fill in portions of their memory with what they see on TV because that's what they saw. So to them, that's part of their life. So they fill in those parts with either inappropriate words or fabricated stories. Perseveration is the continued repetition of words, thoughts, or acts not related to the current context. Again, this is where they get stuck on words that aren't always the best words in the world. They're usually going to get stuck on words that are inappropriate. Multi-infarct dementia. This is where they end up with dementia because of all these small infarcts of the brain. And this can lead from repetitive strokes, right? So this is talking about, as these strokes keep occurring, their brain is basically going to start showing signs of dementia. Well, it makes sense. If the brain's not got all these bleeds and all these clots all throughout it, you're going to start getting demented and a little bit loss of reality, right? So that's going to happen with this. Speech and language and swallowing are typically going to be involved, but usually only if they're having a stroke in the left hemisphere. It's really common, though, for them to have about dysarthria. So 48 to 57% of the patients will have dysarthria, right? So over here, dysarthria after a stroke. And dysarthria, again, is problems with the jaw, the tongue, and the throat. It's problems with the motor components of speech, not the neurological components of speech. Aphasia is a generalized term used to describe the acquired communication disorder caused by brain damage. Aphasia is not the best term for it because aphasia means lack of speech. It would be better for this to be termed as dysphagia because they have difficulty with speech. Now, does that mean they can't go aphasic? No, absolutely, they can go aphasic and lose speech. But it'd be more appropriate to call this dysphagia than aphasia. Dysphagia is difficulty with swallowing, And it occurs, it's only about 12% of the people that have strokes, but again, it's where they have problems actually getting the food and forming an appropriate bolus for them to swallow it. A lot of these patients will tell you they get that feeling where it feels like that bolus is moving super slow down their throat. And I'm sure all of you have had that case at some point. We talked about the two different types of aphasia, right? We talked about Wernicke's versus Broca's. Wernicke's is considered fluent aphasia. Broca's is considered non-fluent, right? Wernicke's speech flows smoothly, but the patient has difficulty understanding spoken language, following commands, and may have problems with what their motor output is. They may be saying words that aren't what they want to say. Non-fluent or Broca's or expressive aphasia, speech is slow, hesitant with limited vocabulary. It's oftentimes sounding like they've got a stutter. And it's not always a true stutter, but the beep, 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 beep is broken in Broca's aphasia. Less common, but I've seen it at least once, is global aphasia. This is where the patient has both problems with production of speech and comprehension of language. If that occurs, that can be very, very, very problematic because they're not going to follow commands, even if they're simple one-step commands. Bowel and bladder dysfunction occurs in about 29% of the patients with a stroke during the acute phase, and that will usually generally improve because most of bowel and bladder is going to be regulated at the lower spinal levels. So that part of the upper motor neuron is still functional. It's not like you had a stroke in that area of the spine. So usually bowel and bladder will return. Can include incontinence, diarrhea, constipation, and it may lead to impaction. So if they're that constipated, impaction is where the body literally forms concrete in the bowel. If that happens, there's only really one way for that to be fixed, and that's usually nursing has to go in and clear it out manually. And they have to do a manual disimpaction of the patient. So literally they have to go in and scoop the patient's poop out of their butt so that it clears out. Yeah, not a fun thought process, right, Erica? That's, hey, we need your help with impaction over here. Nope, I'm okay. I'm good. You can do it. You're perfect. Now, they can give them medication to help with this, right? Milk of magnesia. There's all kinds of medications we can give to help with either diarrhea or constipation. But understand it only helps as long as the patient takes the medication. If the patient stops taking the medication, problems can return. The more physical activity we can get them doing, the better their overall bowel and bladder function is going to be. It even works with you guys. The more physical activity you do, the better your bowel and bladder function is, right? The more you exercise, work out on a regular basis, the more regular you become. That's kind of the way it works. The body needs movement to maintain regularity. So emotional changes. We can have emotional changes, especially noted with lesions of the frontal lobe, the hypothalamus, and the limbic system. So the regulation of emotion itself. They may get that pseudobulbar affect, which we've talked about before, right? Pseudobulbar affect, also known as emotional lability or emotional dysregulation syndrome, occurs when the patient responds inappropriately to the current situation, where maybe they're in a sad situation. They're coming in and saying that they had to put old Yeller down. And instead of crying, the patient starts bursting out into uncontrollable laughter, right? That's inappropriate to the mood they're in or inconsistent with the mood they should be in. That's a pseudobulbar affect. Apathy, right? We talked about that briefly. It's kind of where I exist constantly. Apathy is where they have a shallower, blunted emotional response to everything going on in the world. I'm starting to get an apathy towards this administration currently. Euphoria. This is exaggerated feelings of well-being, increased levels of irritability or frustration, and or social inappropriateness, right? So this is where the patient is kind of almost the opposite of apathy or the opposite of depression, where the patient just happens to get feeling really good. I'm thinking that if I'm going to have a stroke, I would rather have a stroke where my emotional status goes towards euphoria, where I'm constantly happy, even though my life sucks because I just had a stroke, than going towards apathy or depression. I think if I'm going to have a stroke and my emotional effect's going to be that way, you know what? Fine. Make me happy even though I'm completely sad. At least I can live in a happy, deluded world. Depression occurs in about 1/3 of patients with strokes. right? And may be characterized by persistent feelings of sadness. This is when we talk about that major depressive disorder. And major depressive disorder is really common in almost every neurological problem we'll ever encounter. They may have loss of energy or persistent fatigue, poor concentration, changes in weight, sleep patterns. When a patient is depressed, it affects their whole overall life cycle. And if any of you have ever suffered from a major depressive event, you understand that. It really affects everything you do in life. It's not just, oh, I feel sad, I've got to snap out of it. No, it affects everything you do. Depending upon what hemisphere is affected, they may, have different types of hemispherical effects. Other things can happen, dementia and delirium, right? Dementia, long-term confusion, delirium, short-term confusion. Hallucinations, they may see things, right? They're like, oh, look over there, my grandson's here today. And no, there's no grandson there. I've had patients with strokes that have seen, bugs crawling on walls that aren't there. They're seeing their pet that they haven't seen for 20 years. Agitation, irritability is going to be common with this. When you think about it, that makes sense. If you lose part of your function, you are going to become irritable. You want that function. You just had that function. Now you don't have that function. It is going to make you mad. So don't take it as a personal offense if the patient gets aggravated while you're working with them. That is a normal output of having a stroke. Confusion, very common. Delusions, right? Where they start having such things as delusions of grandeur or delusions of minority. They may think they're receiving more care than they should or less care than they should. And then ultimately, it can all lead to a psychotic break where you separate from reality. It's pretty rare. I haven't really seen a case where I've had a patient that has had a total psychotic break, but it can happen. I've known other clinicians who have had patients that have had full-on psychotic breaks. And again, usually that's when you have somebody that's got something majorly happening in the cerebrum in that higher functioning area or the frontal lobe. But, it's a possibility with the stroke that they can end up with psychosis. So some common indirect impairments, obviously musculoskeletal problems. They'll have loss of motion, joint contractures, edema, pain, disuse atrophy, right? Muscle weakness, they can end up with osteoporosis, which then increases the risk of fracture. They can end up with neurological symptoms, right? Such as seizures and hydrocephalus. They can end up with integumentary symptoms, skin breakdown and decubitus ulcers, which I've got to change that term into pressure injuries from pressure, friction, shearing, and they can end up with maceration. Remember, maceration is like that pruning that you get when you get in the bathtub for a long period of time or in the pool for a long period of time, where the skin becomes kind of mushy, right? The more the patient lays in one position, the more likely they are to have integumentary issues. That's why we've got to rotate a patient every 2 hours, right? Really common for them to have decreased sensation, abnormal patterns of movement and stuff like that. So it's really common when they have these abnormal movement patterns, the decreased sensation, that they're going to end up with skin breakdown because they don't necessarily feel that skin breaking down. Well, how do we prevent that? Well, keeping their skin dry and clean. Right? Making sure that they're being cared for by nursing, protecting them from injury by having them positioned, turned, and transferred properly. We may have to use pressure relieving devices, such as cushions for the wheelchairs, special beds where the air kind of moves around as the patient's in bed. Proper nutrition and hydration are key, though. These patients need to be getting food, even if it's, being fed to them through a tube, so that they actually are getting the appropriate nutrition, the appropriate hydration to keep them functional. What can happen with the cardiovascular syndrome? Well, DVTs and thrombophlebitis, right? It's really common, like 47%, that's pretty common, with a 10% rate of death due to a pulmonary embolus. If you've got a clot in the brain, it's likely you're going to get clots elsewhere, right? So clinical signs include unilateral leg swelling, dependent edema, meaning as the leg is down, the leg swells, which most of the time when we're sitting upright, our legs are down. This is why when you're on an airplane, It's really good for you to get up and move a little bit while you're on that airplane. Maybe dull, kind of achy feeling in the calf, tenderness in the calf. Bed rest and elevation limb with meds, so anticoagulants. I know I put blood thinners there because that's what everyone calls them. They aren't blood thinners, they're anticoagulants. A blood thinner is water. An anticoagulant is the medication to prevent coagulation or blood clots to form. Prevention and early mobilization and ambulation are key, along with the prophylactic use of heparin or some other anticoagulant. Within reason, if they're on high doses of anticoagulants, they may be on bed rest until they can get off of those. Because even something as simple as walking down the hallway can cause massive bruising and clotting. So you have to be aware of what medications your patients are on and how they affect therapy. But again, the more they move, the better their overall function is going to be. Cardiac function, most patients with stroke are usually severely deconditioned and will exhibit low work capacities. Well, that makes sense. They've got their brain blown out. They're not functioning as well. They may have acute illness, bed rest, and limited activity levels. This can reduce the cardiac output. It can reduce maximal heart rate, increases resting and exercise blood pressures because the blood pressure is going to go up to compensate for the heart rate going down. Oxygen uptake may be low. They might have decreased vital capacity. This is where we're going to come in and teach them the ACB, the active cycle of breathing. The more we can get that chest to expand and open up, the better we can perfuse the blood with oxygen, the better they're going to be functionally cardiac-wise. And then we talk about the lungs. It's really common for them to have really low lung volumes, decreased pulmonary perfusion, vital capacity. And then the chest wall will alter with chest excursion. So instead of expanding nice and wide like it normally does, it sinks in and they get kind of that sunken chest look. This is why that second phase of the ACB is important, that thoracic expansion, where we cause that chest wall to kind of expand out and spread those ribs. Aspiration. This is probably one of the most common causes of rapid death following a stroke. This is where the penetration of food, liquid, or saliva or gastric reflex occurs in the airway. And it occurs in about 1/3 of patients with dysphagia. So this is where the patient's muscles of mastication and swallowing are affected, chewing and swallowing, right? And so instead of that epiglottis blocking off that windpipe and not letting any food down, the epiglottis is impaired, and so food goes down into the lungs. If food gets down into the lungs, bad things can happen. You've all had it where you've breathed in something you're drinking and how bad that makes you cough. Well, just imagine what it'd be like to get a huge chunk of steak or something down into your lungs. It's not going to be functional because the body doesn't have the ability to break that down. So they can literally choke and die because their function is just decreased. The recovery is usually fastest in the first weeks after onset. This is why it's important to get physical therapy literally as soon as we possibly maximally can. A lot of studies that are out there show that physical therapy should start day 0 after stroke or day 1 after stroke, getting them up and moving as soon as possible. The most early recovery attributed to diachesis or transition of inhibition of function, meaning that the more that we can inhibit their negative function, the more we can improve their positive function. After those short period or that very first 3 weeks of onset, function gains are made at a reduced rate. I don't know how this screen got messed up like this. I'll try to fix this and re-upload this. And then as they progress, right, as the months and years progress, if they've lost something, it's not likely to come back. We're going to talk about this spinal cord injury as well. At the 12-month and then the 24-month period, excuse me, if you haven't gotten function back, at the 24-month period, it's likely you're not going to get function back. If you're in that late recovery period, in that past those first few weeks, it is going to require extensive functional training. They are going to have to come to therapy regularly 3 to 4 times a week in order to get gains back. If they don't come for those types of training, they're not going to get those return to function. So Brunstrom's we talked about briefly, right? I told you a lot of times if you look at most of the stuff that talks about Brunstrom's, it talks about stroking and using synergy patterns to get the patient to move. This is kind of their stages of recovery. And again, Brunstrom's typically deals with strokes. So they're going to start with having flaccidity or no movement of the limbs. Then we're going to start getting some basic reactivity syndromes or synergies where they'll get minimal voluntary movement, but spasticity begins to develop. Then we're going to use that spasticity and voluntary synergies to increase spasticity to the point that it may become severe. But we're going to use all of those dysfunctions to help the patient recover. Some movement combinations do not follow the path of either synergy may be mastered with difficulty, meaning if spasticity starts declining, we may start seeing a decline in skills as well as they return to normal basic limb synergies. The Brunstrom's goal is, in the long run, to return the limb to full function and have spasticity disappear. It doesn't occur with all patients. Honestly, a lot of patients that have strokes will have spasticity long into their life. And there may not be much we can do about that because, again, they literally have brain damage, right? We can't repair the brain. It's not like we can go in and say, oh, look, this part of the brain's dead. Let's cut it out and we'll put a new part in. We're not cars. So it's very common for patients to end up spasticity a long time down the road. So what do you need to know about Brunstrom's? Well, again, I talked about this briefly. Brunstrom's just is primarily in stroke. So here we have a picture of a typical stroke patient, right? And if you're looking at this, you can clearly see it's his left side that's affected. That means it's probably a right-sided stroke in the brain. His left shoulder is kind of sliding down. He's starting to get subluxation due to hypotonicity. He's got that pusher syndrome, that lateral trunk flexion towards the affected side. He's not trying to weight bear down through that arm, right? Because he's starting to ignore it. And he's starting to prefer using the good side for motion. If you look, he's got that good hand wide and open because he's trying to weight bear through the good side and not through the affected side. The one thing I like about this picture, especially, is this person has a gait belt on the patient. If you are working with a stroke patient, if you are working with a patient that has a spinal cord, if you are working with a patient that has a TBI, you must put a gait belt on these patients. They will fall on you. They will have problems. Do not be stupid and end up having problems with that, right? Make sure you've got that gait belt on them so you can protect not only them, but protect yourself. I guarantee if a patient goes down and you don't have a gait belt on them, you are going to hurt yourself as much as them because you're going to throw your back out. You're going to twist a knee. You're going to do something stupid in order to save them. Or in my case, like I did, end up with a broken neck. I actually had a gait belt on the patient. So this is kind of looking at this flex and synergy. This is the way the patient typically is going to present once they start going spastic. So their arm is going to curl up very much almost into a fetal type position. They're going to have downward rotation of the scapula, shoulder internal rotation along with adduction, elbow flexion, pronation, wrist and finger flexion. They're going to kind of curl up and in. With the leg, it's going to be pretty similar. Right, they're going to go internal rotation with ankle supination and great toe extension. Knee flexion is consistent, and they're going to have some pelvic retraction where they're kind of pulling back. So again, if you look at this with a stroke patient, they're often going to revert to that almost fetal position on that stroke side if they get no therapy. There have been patients, I've actually seen at the one hospital I was worked in where there was a patient that had a stroke, and the family members bring him in for acute therapy. And it wasn't acute, it was chronic therapy. He had a stroke 2 years ago and had no therapy. They just kind of took care of him at home. And his upper extremity and his lower extremity were completely and utterly almost fibrotic at that point. They had contracted up and in, and there was literally almost nothing we could do for them because they had neglected the patient's functional status for so long. The body basically shut down and said, I don't even want to have these functional limbs anymore because they contracted up. So what do we do with these patients? Oh, we got a question. Hold on. Has there any research on whether certain risk factors may be more common to affect certain parts of the brain? So Dylan, that's a great question. So Dylan's asking, is there any research that says, well, does this cause this? And there are some studies out there that show what parts of the brain typically are affected in heredity, meaning that if you've got a family member that may have had a pontine stroke, there are certain different types of strokes that are more likely to occur due to heredity. But for other risk factors, especially modifiable risk factors like smoking, a fatty diet, stuff like that, no, that's actually just Russian roulette on what part will be affected. You know, it's not like, you know, if I have a fatty diet, I'm more likely to get an anterior cerebral artery stroke. No, it's literally, you can get whatever happens. It depends upon where that blood clot goes or what blood vessel ruptures. So it literally, like I said, it's a great comment, great way of saying it. It really is like Russian roulette at that point as to what happens. You're taking your life in your own hands at that point. So in the acute phase, right, we're going to start off with low intensity until the patient is medically stabilized. You may not always have the ability to do maximal therapy, but even bed mobility and bed exercises are beneficial to stroke patients. Even passive range of motion is beneficial to stroke patients to help prevent them from getting long-term spasticity. All the studies though have shown early mobilization is key. The more we can get them up and get them moving, the better we can get functional return. Early stimulation is important, and getting the hemiparetic side useful, right? I talked briefly about that constraint-induced therapy idea back when we talked about the different therapy ideas, where we force them to use that affected side. Moving stuff to the affected side is really important, at least from what I've seen working with stroke patients. If you can encourage them to use that side, have family members talk to them on their affected side, reorganize the room so that it's towards that affected side. That forces them to have to think about that affected side. There has to be an organized plan of care, and it has to be discussed with both the patient and the family. They have to understand what their goals are. We have to monitor for DVTs and changes in blood pressure and cardiac arrhythmias. Why do we have to do that? Well, because we don't want them to stroke again. And then we're gonna have to work on positioning programs. We may have to work with nursing on this, telling them that we may want this patient rolled more than every 2 hours because of potential breakdowns in the skin and stuff like that. So that's an acute phase. In that first couple days after having a stroke, hopefully, you know, 5 days out, we can get them to an acute rehab center, but it doesn't always happen. Sometimes those patients have to stay in that acute hospital for quite some time. Excuse me. So once we end up past that acute phase, now we're getting into the chronic maintenance phase. It's really recommended, at least in every stroke patient I've had, to try to get them to rehab. Or if you can't get them to rehab, at least to a TCU, a transitional care unit. Because we know the more rehab the patient gets, the more therapy the patient gets, the better their outcomes overall are going to be. They should have comprehensive services, meaning PTA202, right? Speech therapy, physician, nurses, respiratory therapy, everything along those lines. I'm not sure what I put SW there for. I don't know what I don't know why I put SW. I think that's supposed to be respiratory therapy, and I somehow messed that up. Patient and family are an important part of the team, meaning they have to have some involvement. If they don't have family, this can be really problematic because the likelihood of going home without a solid family background at home or some solid family help is pretty low. If a patient has a low affect, meaning that they had a stroke, but overall it's not as severe as some of the other major ones, outpatient or home health services can be optional for those as well. I would recommend that every patient continue therapy for an extended period of time after a stroke because they never know how things are going to go. And they want to have some help with monitoring it. We may have to assist the patient in getting adaptive equipment, such as wheelchairs, walkers, reachers, grabbers, sock aids, stuff like that, because they may not know what they need. And then as we get further on the line, we may have recreational therapy come into play as well, where the patient's going to have some help resuming normal social and recreational participation, right? Getting them back to their everyday function. We've talked about this throughout all of neuro that we've talked about. The goal is to either get the patient back to normal function or compensate for that loss. That is how we get patients better, right? And we're going to concentrate on safety and energy conservation in the process. So if they're in the acute phase, right, mechanisms of inflammation are mobilized to the site. They come with their own issues in the brain itself, right? So if the brain has an acute stroke, glutamate and aspartate are common neurochemicals that arrive on site and actually damage surrounding tissue by their presence. This is called excitotoxicity. This is where the brain itself, I talked briefly about this, says, oh, look, I've got this dead area, so I need to prune this off. What's going to send in some glutamate and aspartate to kind of glial it off, kill it off. But in the process, it's going to send out toxins in the surrounding area and may further damage other brain issues, right? The management of any acute condition is to mitigate, I can speak today, the inflammatory process to reduce negative signs and effects of inflammation. We do have to reduce swelling. We do have to allow them to rest. But at the same time, we understand the sooner they get to therapy, the better they're going to be. So we have to balance that rest, just like an ankle sprain, right? We want to elevate, rest, ice, compression, elevate that ankle sprain. But we also know that we need to have some functional movement with it in order to keep that ankle functional and patent. So we have an examination. Now comes the PT. They're going to come in and diagnose, along with the doctor, the classification and specific practice patterns. They're going to look at what's going on with the stroke and say, this is what we need to do. Excuse me. They're going to monitor recovery from the stroke. They're going to identify patients who are most likely to benefit from rehab. So they have to kind of come in and go, okay, this patient's likely to do well at rehab. This patient's not. Develop specific plans of care, including anticipated goals, expected outcomes, prognosis, and interventions. And then monitor the progress towards those goals, right? They have to do periodic reevaluations based upon state laws. Determine the need for referral to another practitioner, and then plan for discharge. They will eventually leave every process, whether it's acute care, whether it's rehab, whether it's traditional care unit. We're always going to try to pass them off evenly to that next level of care, even if that next level of care is their home care where their family's taking care of them. So these are all the things the PTs are going to have to do. This is a not all-inclusive, not all-compensating list, but they're going to have to do a lot of this. Patient history, level of consciousness testing, communication, cognitive, emotional, behavioral states, cranial nerve integrity, sensory integration, perception, joint integrity and mobility, tone and reflexes, voluntary movement patterns, all of this, the whole way down this list, your PT is going to have to do in the eval, right? This is why a lot of times with strokes, the evals themselves are a higher level or higher reimbursement eval, just because these stroke evals take a long time. I've seen 2 hours with the PT doing a stroke eval, and by the time they're done, the patient is just literally, utterly, and completely exhausted, just because they're not ready to fully function at that level. Excuse me. So there are a couple different frameworks for intervention, right? We can do neurodynamic theory, PNF, constraint-induced. We can do Brunstrom's. What we have to look at is what is the best evidence-based practice out there. We have to return sensory function. There is a lot of studies out there that show as sensory function, the ability to feel and sense and propriocept where we are in space, motor function returns with it. Keep them from actually losing sight of having an arm or losing sight of having a leg or losing their eye, right? Through that neglect. We can teach them to stroke and touch those areas so they remind themselves that's part of their body. Superficial and deep pressure are good. Approximation, so where they do weight bearing through that joint. If they're having vision problems, include visual scanning and tracking. Verbal cues are big so they can actually hear things, right? Across midline reaching towards the involved side. Bilateral use of the upper extremities, especially when neglect is present, is huge. You want to improve flexibility and joint integrity. So soft tissue and joint mobilizations are big, right? Remember, if it is a muscle, joint mobilizations aren't going to help us. Joint mobilizations are for having problems with the joint itself, right? So when we talk about having that capsular pattern, that would be a time we'd use joint mobilization. If the problem is the muscle itself, we may have to stretch and or mobilize that muscle in order to get it moving. Range of motion, positional strategy, and splints are big. So be careful of reinforcing learned disability, right? So don't let the patient start thinking they are having a learning disability and that they're never going to return. They're going to constantly say this, I'm never going to get better. Don't let them get that way. Don't reinforce it. Use compensation as initial access to mobility or late in the game option, not as a best practice. You want to try to get them to do as much as they can without compensation, right? Don't treat CVA patients as if they're lost children, right? If they don't use their abilities, they will lose it just like anything else. Just some helpful tools when you're working with stroke patients, have some hope for them, be that beacon of light, smile, believe in them, be respectful and be kindful. These patients may be the meanest people in the world to you because they tend to sometimes have some neurological deficits. Kill them with kindness. Be the nice person in their view, right? Sometimes that's enough to get them to turn the corner. If you're the person that's providing them that little glimmer of hope, they may actually improve because of that glimmer of hope. And it's really, honestly, when you're working with stroke patients, it really feels good when you see them actually improve. So what kind of things can we do with the upper extremity? Arm cradling, where we take them and have them working with cradling that affected side, almost like a baby. Tabletop polishing, sitting down, reaching towards the floor. Supine clasping and raising the hand overhead, right? Only do if the scapular movement is present. If they have problems with scapular movement, you're going to have to mobilize the scapula first. Ball on the wall therapy is great. Ball on the table therapy is great. Mirror therapy is great. Anything to get them to use that affected side as if it is unaffected is a huge thing. Active assist motions, such as doing this supine clasping the hands together and moving the hands overhead, police, anything like that can help them start seeing that arm as they're moving. The key thing here, though, is as they are moving that affected limb of the upper extremity, they should be watching it intently, right? I talked about this with PNF. When they're doing PNF patterns, they should be watching their limb. It's more important for stroke patients to watch their limb because that leads them reintegrating that limb into their brain. Lower extremity stuff, we can do weight shifting. We can do seated input through hips and buttocks. Plantigrade is standing up where you're kind of leaning forward with your hands on a table with both bilateral extremities and bilateral lower extremity support. Tandem standing, right? Putting one leg back and then putting the stroke leg back to get them to feel the difference in feeling. Uses of different height and standing surfaces, having them stand on a stair on one foot and down on the floor with another foot. And can use to increase hemiplegic side problems, right? You can go back to the joint with most proprioceptive control. Remember that hip, ankle, knee step strategy, right? We know that the ankle is our first strategy for balance recovery. Then it goes to the knee, right? Then it goes to the hip, and then it goes to that drop strategy. And then, or suspension strategy is the other term for drop strategy. And then it goes to stepping. Oh, I got a question here. Hold on. You could. This is where, Renee, so this is going to come in. You're going to determine what's best. If you put that lower extremity on the lower surface, then they're going to have to balance heavily through it, and that may not work as well. So putting it up on the higher surface is probably the best in at least the initial phase. But eventually, we're going to do both because eventually we want them to get functional where they get back to their normal function. And, we all have a preference. If you watch yourself when you're going up and down stairs, we all have our preference which leg we step up with first. But once we step up with that leg, we're going to go step over step over step. It's not like we step up with the right leg, we bring the left leg up to that step. We step up with the right leg, we bring the left leg up to that step. So we're going to eventually teach them step over strategy. So they have to be able to wear or bear weight down through that leg as well. If they can't stand on their own, using stuff like knee stabilizers or lower extremity, blocks for the knee where it keeps that knee immobilized, those can be really beneficial initially until we get control of that knee to provide prolonged static positioning, right? We can use knee braces that have unlocking hinges where maybe when they're standing upright, that knee locks into place in straight standing. But when they need to bend the knee, they can actually unlock the knee so they can sit down. All right, let's take a break here. We'll come back and we'll start talking about strength training post-stroke. So let's take a 10-minute break. Let's stop the sharing here. Pause to resume recording for stroking again, right? So strength training post-stroke. Studies support that graded strength training does not cause any detrimental increase in spasticity. So it's basically saying that, you know, we used to think that if we strength trained a patient after stroke, spasticity would increase because of the fact that we're causing muscle contractions. Well, we've done a lot of research since then, and we now know that strength training post-stroke is kind of important in order to keep strength training or strength in those muscles, and that it doesn't functionally increase spasticity. It may cause some clonus to occur. It may cause a clasp knife response, but it doesn't cause a significant increase in overall functional spasticity, right? For patients with less than 3 out of 5 strength, gravity-limited exercises are important, right? Because again, 3 out of 5 means they're able to move against gravity. So we may have to think about doing gravity-limited exercises, such as using the powder board, sling suspension, aquatic exercises, active assist range of motions, wand exercises, stuff like that. For patients with 3 out of 5, gravity-resistive active movements are the best indicated exercises. So arm lifts, leg lifts, curls, overhead press, all your normal activities you would normally do with a patient, all those normal exercises. So all the stuff you're learning about in Therex too with the upper extremities, right? Patients who demonstrate adequate strength in gravity resisted can progress to added resistance. So once you get them past 3 and start getting to that 4 and that 5 out of 5, we can now start adding additional resistance. You know, again, normal progression is going to be manual resistance first. Learn how strong they are by you being the resistance. Then progress to things like free weights, TheraBands, machines, everything like that. Always remember with stuff like TheraBand and any type of cable machines or anything like that, that there's also going to be eccentric loading on those muscles. So make sure you check the eccentric strength in those muscles as well when you're checking with them. You need to carefully monitor their vitals, right? And their rating of perceived exertion, the RPE. So I know there are 2 different types of RPE. There's the standard Borg RPE, and then there's the modified Borg or the modified RPE. I tend to use the modified, right? So the regular one's, I think, 8 to 22. And then the modified is just 0 to 10. I find that patients understand 0 to 10 a lot better. On a scale of 0 being not hard at all to 10 being, oh my God, this is the worst exercise ever and I'm exhausted. How did you feel after that activity? Oh, well, that was a 5. Okay. We know that they're getting effective moderate exercise at that point. The regular rating of perceived exertion actually does correlate back to cardiac output, and that's why sometimes in a cardiac unit you may use it. But specifically with a regular patient, the modified RPE is just fine. Just ask them on a scale of 0 to 10. How hard was that activity, or how much work are you doing right now? Because most of the time we're going to want to keep them in that at least 5 to 6 range, because at that point that's moderately hard, and we want it to be moderately hard. We want it to be challenging. If the patients are like, oh my God, this is a 9 out of 10 or a 10 out of 10 activity, we might have to step it back some. So it's important to monitor everything. And then again, blood pressure, heart rate, and all that are important because that can be signs of future stroke. So we want to be paying attention. What are warning signs to stop exercising? Lightheadedness or dizziness, especially acute onset. All of a sudden they're like, oh my God, I feel like I'm going to pass out. Now it might be time to stop exercising. Chest heaviness, pain, or tightness, especially with angina, so chest pain. Palpitations or irregular heartbeat. So you check their heart rate, and all of a sudden it feels like their heart's beating out of control, or it's not beating in a regular manner. Sudden shortness of breath, not due to increased activity. That can be a sign of a pleural blood clot, a lung blood clot, right? Pulmonary embolus. If all of a sudden you're talking to them and they're like, okay, yeah, this is rough. You're like, well, we just sat up at the edge of the bed. That can be a problem. Discomfort or stiffness in muscles persisting for several days after exercise. So we're all going to get a little bit of DOMS after exercise. We're all going to be a little sore if we work hard enough. But this is the patient that they have persistent stiffness and achiness in their muscles many days after they worked with you. That's a problem, right? If they suddenly get a headache during therapy, that's a problem. We need to stop exercising them. So how do we manage spasticity? Well, we can use PNF, right? We can also use the antagonist muscle using slow and controlled movement. If my biceps are spastic, I can use reciprocal inhibition by firing off my triceps to relax my biceps. So if I notice that I'm clasped up and my biceps are spastic, I can activate my triceps and it should theoretically loosen up some of that bicep. It may not totally loosen up, but should loosen up some of it. We may have to do some splinting orthotic usage, right? Where we splint them in extended length periods. Or maybe they're stuck at 25 degrees of elbow flexion. We'll splint them out to about 10 to 15 degrees where we're not fully out until we just work their way to 0 again. Weight bearing is really important. If you see somebody that's becoming spastic, get them to weight bear through those joints. That really does help it. We can do NMES or rush into the antagonist muscles again to trigger reciprocal inhibition. Early mobilization is key about everything. The more we can mobilize them, the less they'll become spastic. Stretching the muscle can help. And again, a sustained stretch, not a quick stretch. So a long, low, and slow stretch. Rhythmic rotation of going through one motion, then going through the other. So going from extension to flexion, extension to flexion, extension to flexion. That can cause it to kind of calm down spasticity. Prolonged deep pressure. Go to the center of the muscle belly and place your finger and put prolonged deep pressure on that muscle belly, on that neuromuscular junction. And then rocking movements. And you think about it, this is exactly like something an autistic kid will do where they rock back and forth. Well, the same rocking movements work for stroke patients. If you can get them to rock a little bit with that joint, back and forth, it can cause spasticity to calm down. Motor control. Activities to promote normal postural alignment and control functions that use the extremities. Focuses on disassociation of the different body segments and selective movement patterns. Excuse me. What this is saying is you want to be able to get them to understand that the body moves in parts, right? We want eccentric, concentric, and isometric exercises to control the muscle movement. I can speak today, I promise. Patients with pusher syndrome should be focusing on the patient leaning towards the stronger side, into the PT, into a wall, assist with vertical orientation. Mirror therapy is huge with stroke patients. Putting a mirror in front of them that they can see what they're doing helps them understand what they're not supposed to do. And then demonstration and cues. So you show them, right? The show, tell, do. We've talked about that for the whole time now. You show them what they're supposed to look like, and then they mimic what you say they're supposed to look like. Work on strategy development. The patient actively learns and practices the desired task. This includes going from parts to whole, right? So if we're working on doing sit to stands, we may work on just leaning forward, nose over toes, 10 to 15 times. So they get that. They need intrinsic feedback from inside themselves and extrinsic feedback from mirrors and from you. Practice, practice, practice. The more you have them repeating activities, the more likely they are to retain that activity. So they should be doing as much practice as they possibly can when they're working with you. So here we have a bunch of different strategies. I would include this in your clinical binder. I try to put them on different ideas for you here. Intervention strategies that kind of work on postural control and functional mobility. Rolling is important. Supine to sit and sit to supine. Sitting at the edge of the bed. Bridging is really important for bed mobility and strength for sit to stand transfers. You know, sit to stand and sit down transfers, teaching them how to stand up and sit down, stand up and sit down. Helps with the overall function of the body. That is a really, really good activity for closed chained, hip and knee extension activities, is doing sit to stands. Standing in plantigrade and modified plantigrade, meaning where you're standing with one upper extremity or both upper extremities on a surface and shifting side to side, back and forth, can really help with that patient starting to get good proprioception through those areas that might not have the best proprioception. Generalist standing, right? Progress from half sitting posture to bilateral support to standing up fully on their own. Even if you have to get them into a standing frame in order to get into standing, which standing frame is just a assistive device that helps them stand upright. Even that can be beneficial. Transferring, getting the patient out of bed is key. It doesn't matter if you get them out of bed and they get up and they fall asleep in the chair. Getting them out of bed and getting them vertical is huge. The more the patient spends horizontal, the more likely they are to develop complications from their condition. Getting them vertical is important, right? Transfer to both sides, even towards their affected side. Now, when you first start, excuse me, you may transfer only to the good side. That's okay. The reason we may start transferring only to that good side is because that's the side that's strong and they're likely to catch themselves if they start falling. But eventually you're going to have to train and teach them to go to both sides, right? Work on the good side and the bad side. Involved knee may need to be stabilized as well. So if you have a really weak, knee that kind of pops in and out of function, they may need to have bracing or support on that knee, or even you blocking that knee so it doesn't buckle on them. With upper extremity function, you really should closely coordinate this upper extremity function with an occupational therapist or a specialized hand and upper extremity specialist physical therapist and PTA or whatever. In general, PTs and PTAs that go out in the clinic are not specialized in upper extremity function. We are more, again, even though it's not the best to say it, we're typically more gross movement of the lower extremities, right? But there are therapists that specialize in hand and upper extremity therapy. They should be really involved when we're talking about improving upper extremity function. As a PTA, you can specialize in hand and upper extremity function. It's not just limited to PTs and OTs. I always love it when I go to the hospital and I hear that, PT is lower extremities and OT is upper extremities. Not really, right? PT is more gross movement, and OT may be more ADL, IADL type activities, or it should be, right? We want to use the upper extremities as postural support, right? Extending the arm down for weight bearing, pushing up from sideline, dynamic stabilization, reaching. Start in sideline if the patient has minimal control for balance, right? So start where they're in sideline and reaching with that affected upper extremity. Have them reaching and touching cones. Have them reaching and grabbing for the remote control, getting their drink. And then progress that reaching to seated, and then maybe eventually to standing. Providing them with supportive devices, right? Patients with hypotonia or lack of tone are at risk for traction injuries when they do stuff. So we may have to provide things like humeral cuff to prevent subluxation. Slings, we may provide some taping techniques and NMES to keep that joint from becoming subluxed. They can sublux their elbows as well. They can sublux their wrists if they don't have that tone to maintain normal muscle control in those joints. Manipulation dexterity. Remember, agility, feet, dexterity, hands. We're going to start using the affected side to stabilize during activities, hold a paper while writing, stabilize a plate or a food container, and then progress to controlled grasp and release techniques. So moving towards more fine motor skills. There are different types of enhanced training activities. We can do constraint-induced therapy, which I talked about, right, where we obstruct off the good side and only allow them to move with the affected side. Can do bilateral arm training with rhythmic auditory cueing, backtrack. This is where they're going to be doing bilateral arm movement, and there's going to be audio cueing them to do left, right, similar to what you'd have in the military. EMG biofeedback, right? This is another form of a modality that we can put on that arm where it will beep at them when they reach certain levels of contraction of the muscles. I'm hoping Dr. O'Neill covered that with you guys, but it's a really good thing to help the patient to realize if they're actually activating the right muscles or not activating the right muscles. It beeps when they activate the right muscles. We can use NMES with optimal results obtained with task-specific training. So if they're having problems maybe raising their shoulder up, let's work with raising the shoulder with some Russian. So we get that shoulder coming up with the Russian, and then they reach and do dynamic tasks while they're actually doing the Russian stimulation. Shoulder pain is really common with patients that have had strokes, and most of it is going to be because they're going to end up with a subluxation. Hemiplegic shoulder pain incident rate is about 38 to 84%, depending upon the type of stroke they've had. Can lead to subluxation, shoulder impingement syndrome, adhesive capsulitis or frozen shoulder, and even all the way up to CRPS and RSD, right? So paying attention to what your patient's saying about the shoulder and their arm can be really important to their functional outcome of their shoulder and their arm. I know we really get hyper-focused again on PT of the lower extremity and getting them up and walking, getting them out of bed, because that may all be all the time we have for them. But we have to pay attention if the patient's talking about getting pain when they haven't had pain before, or you're starting to notice, excuse me, when you're walking your patient, they're not using their upper extremity as much as they used to. They're not weight bearing down through it. It's really, really, truly important to pay attention to that and then coordinate with the therapist that is functioning and working on that. PNF patterns are really good. D1 flexion extension are really good to counteract obligatory synergy syndrome. That is, D1 is probably the best for getting them out of that hyper flexed posture that they're going to end up with spasticity. So especially getting out of that D1 extension, getting that leg out to the side and kind of extending the toes out and everting the foot. Bridging and hip extension with knee flexion over the edge of the mat is really good. So getting those bridging up and down. Lower trunk rotations, where they're rotating their trunk side to side to side to side. They can be done in side lying, supine, hook lying, kneeling, standing, anything to kind of get that trunk kind of rotating back and forth. Pelvic shifting while sitting on a TheraBall, right? So get them up there and start doing anterior, posterior pelvic tilts, lateral pelvic tilts, circles with their pelvis, right? Anything to kind of get that pelvis realizing they're weight bearing through it. Getting the extensors and the flexors to work in the knees by doing long arc quads, short arc quads, stand-ups, partial wall squats, good idea for these patients, but also be aware that as you bend that knee, it's likely for that knee to buckle if it's really weak. NMES and kinesiotaping can be highly important for patients that have lost muscular control, especially if they've lost something like dorsiflexion, plantar flexion. NMES can be really huge for helping with that. Balance, well, balance training we're going to talk about with vestibular heavily, but balance training carries across all methods of neurological issues. Once they are stabile, we can work on mobile. They cannot work on mobile until they are stabile. So once they've got static stability achieved, now we can start working on balance stuff by changing their base of support, right? If we start in seated, the first type of seated we should be starting with is 2 hands at their sides on their bed, using that for static balance support. Then we can progress to taking 1 hand off. And then we progress to taking 2 hands off. And then maybe we'll change the base of support or what they're sitting on. Then we can progress to eyes open, eyes closed activities. Changing the feel of the support surface, having them sitting on a hard mat versus having them sit on a Dynadisc or an Airx pad. Sensory input changes. Change the general feeling of the type of stuff they're sitting on. Maybe sitting on a chair, a leather chair versus a hard plastic chair. That provides different sensory inputs. Where are their arms in relation to balance, right? Are they holding on? Are they not holding on? Are they doing 2-finger support? Are they doing no finger support? Start coordinating upper and lower extremity movements, right? Picking up your leg, putting the leg down. Picking up your other leg, putting your leg down. Reaching out with the right hand, reaching out with the left hand. Reaching out with both hands. Cross-reaching with right hand, cross-reaching with left hand. That's going to start involving trunk movements where we're starting to rotate and maybe flex the trunk. And then we're going to start going to destabilization of functional activity. So we're going to start challenging them where we're going to make those normal functional activities, like maybe reaching over an overhead shelf, a little bit more difficult by changing the surface they're reaching on, or having them outside of their base of support when they're reaching. So we teach them to always stay in their base of support. Dual task training, where we're working upper extremity and lower extremity at the same time, or maybe we're working on functional as well as strength training at the same time. And then change the environmental condition, what's around them. Closed environments, great initially for a stroke patient, but eventually we want to move them to a more open environment where they're encountering more interaction with the real world. Walking and improved locomotion, meaning getting moving. Body weight support systems with an overhead harness are really great for this patient. So if you haven't seen them, there's systems like the light gate system. There is the I think it's called the trail gate or the rail gate. I forget what it's called in the hospital, where they literally have rails in the ceiling that you can hook your patient into, put them in a support harness that takes certain amounts of their body weight off, and they can get up and walk with a 40-50% body weight reduction. Gait training, use of parallel bars to start with, and then moving towards ambulatory aids is important. Be safe. If you've never worked with your stroke patient, they're an acute stroke patient, get them to the parallel bars. Don't think, oh, well, I'm just going to stand them up here with myself. This is going to go well. And then your patient falls, right? We've talked about that. Patient safety is key. Functional and task-specific locomotor skills and elevation activities are important. Changing their heights, going up and down a curb step, stepping up and down over obstacles are important. We also have to think that locomotion isn't only walking, because we may not be able to get the patient walking. They may have had a stroke that it completely has blown out their left lower extremity, and they're not going to get it back. At that point, we have to start thinking about wheelchairs. But if we think about wheelchairs, we also have to think about the different equipment we need with that wheelchair. I know in PTA201 rehab, you guys talked about ordering wheelchairs. If you ask a PT how much experience they've had in placing a wheelchair order, most PTs will say, we place wheelchair orders. It's pretty rare that PTs have extensive wheelchair training experience, mainly because they just don't get that where we do. We get a lot more training, and you guys had it with Dr. O'Neill, or not Dr. O'Neill, with Dr. Sokel. I hope she gave you that wheelchair ordering form that I kind of developed. It's funny, about 5 of the clinics in town now use that order form for ordering wheelchairs, just because it provides everything that the wheelchair manufacturer needs for building those wheelchairs. But you have to think about what alternative equipment you might need on a wheelchair. Do you need a seat cushion because the patient's going to spend extended times in that wheelchair? If they're going to spend extended times in the wheelchair, that normal sling seat they have is just going to be a pressure injury developer. And even with something like a pressure relieving cushion, notice it says pressure relieving cushion. It doesn't say pressure removal cushion, right? They're still going to have pressure, so they still need to move. And again, not all PTs have had very little experience with wheelchairs, but most have, especially if you're dealing with those that are PRN or have worked as outpatient for the majority of their life. They really don't have a lot of experience working with wheelchairs. We tend to deal more with wheeling ordering. I can speak, ordering wheelchairs than the PTs do. They're typically going to have us assess the patient for size and type, and then we have to go back and talk to them and say, hey, do you think they're going to benefit from this extra accessory? Do you think they're going to, and again, the more accessories we add to a wheelchair, the more expensive that wheelchair becomes. So we have to be thinking about the patient's financial availability as well. It's great to get every patient a $35,000 wheelchair, but not everyone can afford it. I've seen wheelchairs that, the high-end, lightweight, really good fluid ball bearing wheelchair, stuff like that, that are in the $30,000 to $40,000 range. Carbon fiber frames, carbon fiber wheels, everything like that, which are great for athletes. But, 78-year-old Mabel may not need a carbon fiber wheelchair. I'm just saying. Or maybe 78-year-old Mabel might need some carbon fiber parts because the carbon fiber is going to reduce the overall weight of the wheelchair and allow her to move it better. So these are the things we have to think about. If I've got a patient who droops forward a lot during seated activities, I may have to think about getting seat belts on the wheelchair. If I've got a patient with lack of head control, I may have to get a headrest with some headrest supports. Just be aware that if you've got a patient that kind of leans forward in a wheelchair and you decide, well, I'm going to solve this by putting a gait belt around their chest and attach it to the wheelchair. What have you done to that patient at that given moment if you put that gait belt around their chest while they're in a wheelchair? What have you done? I haven't got a lot of interaction today, so I'm going to try to get some interaction. Yes, you've done a restraint. Exactly. And we know that restraints are what? Restraints are against the law, unless they're doctor ordered, right? So be aware of that. Now, the big question I always get is, well, what about when we order a wheelchair and the wheelchair has harnesses for the patient? Well, what are we going to do with that? We're going to teach the patient how to put the harness on. So we are not restraining the patient. The patient is restraining the patient, right? I know it's a little fine kind of, it's like, what was that comedy movie, Walk the Line or whatever, right? It's a loophole. It really is a loophole, truly is. But most of those harnesses that we're going to put on have quick release buttons that if the patient needs to get out for whatever reason, there's a button they can press and all those seatbelts release. It can be really fun with kids that have those because for some reason, the only button those kids can use on the wheelchair are those quick release buttons. And so there's, you get them in the wheelchair, you get them all harnessed in, and then you turn around for 1 second, they press the button, they're falling out of the wheelchair. Because kids will find ways to do that. Kids will get out of gait belts, by the way. You can use the best gait belt in the world on a kid, and they will get out of it. They're like Houdini, right? But any type of belts, anything you put on a patient like that become restraints in those wheelchairs. So you have to be paying attention to that. What if you've got a patient that has a pretty bad subluxation on the left shoulder? What kind of a different type of armrest could you order for them that could help with that? You guys remember from back when you ordered wheelchairs with Dr. Sokel, or did you guys learn anything about that? So you could get them a desk arm wheelchair, where on that left side, they've got almost like you remember when we were in elementary school and you had those stupid desks that the chair was attached to the desk, and when you sat down, you kind of slid in through the side? Well, they make those type of armrests for wheelchairs where it's got a little bit of a desk arm. Get that desk arm up and get that arm where they can see it. And that'll help increase the superior force into that joint and provide some pressure up into it and keep that from subluxing as much. There are all kinds of things we can do. We maybe get a higher armrest on the left side than the right side, right? Because armrest height's important. You have to make sure you measure your patient appropriately, right? You need to get their leg length, their seat depth, their seat width, their back or height, right? You need to make sure all of that is functional. You need to understand if the patient is going to need a manually propelled wheelchair, a caregiver only wheelchair, or maybe an electronic wheelchair. And I know I'm not teaching that class anymore because I used to teach PTA201 rehab. That was lead into this. But understand that when you put a patient in a wheelchair, you are basically saying, unless it's, for a couple of weeks, unless you're saying, okay, I'm going to give them a wheelchair for 4 weeks and it's gone. As soon as you put them in that wheelchair, you are sentencing them to lower overall function because they are going to spend time in that wheelchair and not do weight-bearing activities, which means they are going to gain weight, right? It's really common, especially, I've seen it in kids a lot. That whole term when you're in college, that freshman 30, it's really common for kids to gain 20 to 30 pounds being put in a wheelchair. It's same thing with older people that have strokes. They're typically going to put on a little bit of weight in that wheelchair. So when you're measuring for a patient, right, If you're kind of in that half size range where you're like, oh, well, they could be a 17-inch wide, but they could be an 18-inch wide, you may have to think about going, well, I may have to go 18 inches because my patient's going to put on some weight. On the East Coast, when we're ordering wheelchairs, we have to consider winter, right? You know, in Nevada, winter means that now we are able to go outside. That's pretty much all winter means. And maybe some of you might turn on a heater, not particularly me, but maybe some of you might turn your heaters on. Well, on the East Coast, especially the Northeast Coast, and then even this, I'm going to say even in the central part of the country, you know, Dakotas, you know, there shouldn't be North and South Dakota. Why do we have North and South Dakota? Why do we just not have the Dakotas? You know, Montana, those regions, it gets cold, right? If you live in Fargo, it's a totally different world than living here in Las Vegas. So you have to be thinking about that. Clothing may be different, right? They're not going to be going out in a hospital gown. So what could you have the family member do when you're measuring for a wheelchair? What could you tell the family member to bring in for you? Their normal clothes, right? What do they normally wear on a daily basis? I remember I said to a family member, I said, hey, can you bring in, we'll call her Mabel's normal clothes that she wears on a daily basis, so that when I measure her for a wheelchair, that we've got everything set up. And Son brings in Mabel's normal clothes, and it turns out Mabel likes to wear like velveteen, you know, fleecy type material. And it was funny. I'll never forget the one he brought in was this sparkly, bedazzled cat set of fleecy, I don't know what it was, but it was funny, but we put it on her. And when we sat her down in the wheelchair, because it was this really soft velveteen material, she kept almost sliding out of the wheelchair. It was just like she was sitting in oil the whole time. She'd just be in there and we'd turn around for 5 seconds and she'd be slumping way down in the wheelchair because her clothes causing her to slide. That was actually really important to see, because if they hadn't brought in her normal clothes, we would have known she wears that type of clothes. We wouldn't have had to talk about it. And what we ended up doing is putting some Dyson down on the seat so that she didn't slide all over the place. Those are the type of things that take us from, you know, just a base level PTA, base level PT, to being a quality providing care for your patient. Do you want to give every patient, so we put Dyson, you guys know what Dyson is? D-Y-C-I-M, I think is how it's spelled. Don't quote me on that. D-Y-S-U-M. It's been a while since I saw it. Yeah, not the vacuum. We're not doing Dyson. Dyson is basically the way you think about it. You know that material that you buy to put under your dish rack on your counter for your dish drying? That kind of plasticky, webby stuff that keeps things from sliding, right? D-Y-C-E-M is how it's spelled. So D-Y-C-E-M, Dyson. It's that stuff. It's very similar. Now, honestly, in a quick pinch, that material works just as well in a quick pinch than Dyson. Dyson itself is really specifically designed for anti-slide, right? But in a quick pinch, it's nothing to have. It's not a bad idea to have some of the cheapy, you know, dish stuff just sitting around to use, because it really does help keep patients from sliding around. You know, it's definitely rubberized. It definitely has texture to it. But in that case, with little old Millie or Mildred, I forget what I named her at this point, it kept her from sliding out of the chair, right? And it was just a simple thing. And I don't actually think I used official Dyson at that point. I'm pretty sure that the hospital I worked in was cheap and just went to the dollar store and got dollar store anti-skid for dishes. But it still worked. It kept her from sliding out of the chair. And then what we did is we ended up getting her a seat cushion that kind of put her in a posterior pelvic tilt and kept her back in her chair. But it was funny because I remember talking to her saying, hey, you may have to think about wearing some different clothes. And she's like, so Hector says we use Dyson a lot over at his clinic. Exactly, right? And here's the thing. I always found this out, Hector, is You have clinics that have either used DISM effectively and use it a lot, or clinics that haven't learned what DISM is yet and don't use it at all. It seems like once people start using it, they're like, this is the most glorious material in the whole wide world. Why did I not know about this? Because you can use it for so many different things, right? Be aware, especially with COVID nowadays, we may not want to share pieces of DISM between patients. Probably not a good idea, right? Because, you know, this is just like, and here's the thing is in the outpatient world, and even in the inpatient world, when in the inpatient world, they're being tested. But in the outpatient world nowadays, it's very similar to MRSA, right? When patients come in the outpatient world, they're not necessarily tested to see if they have MRSA. So we may be encountering patients on a daily basis that have MRSA and we don't even know it. Same thing with COVID. We may be encountering patients that have COVID and not even know it. So we've got to act like the patient has it, which means we should be cleaning all of our surface, cleaning all of our materials, maybe individualizing TheraBand and DISM for that patient. Get a little baggie, put their equipment in a little baggie and keep it up on the front desk where you can get it when you need to see them, that type of an idea. But man, you're right. You're right, Hector. DISM gets, once you start using it, you're like, oh, I could use DISM for this. So I could use DISM for this. It's kind of like the duct tape of therapy is a good way of thinking it, right? It really is, right? You can use, yeah. Good. So yeah, Hector says, I usually cut a piece for the patient and then save it in their file. Exactly. So that's always there for them. But you know, in the redneck world, the two most important things that we have in the redneck world are duct tape and WD-40. Well, DISM kind of serves the purpose of being the duct tape for the patient. It kind of keeps them from moving, right? Little Millie kept sliding out of her chair. She wasn't supposed to move. It's not really appropriate to duct tape her to her wheelchair, although you may think about doing that sometimes. It's not appropriate to do that, right? But DISM can really act and help with that. And that went way off tangent, but that's okay. Sometimes it's good to go way off tangent. Limb load monitors, specifically pressure plates, right? Especially if you're working in a clinic that has those really nice pressure plates that we can find out, are they putting the same amount of weight on both legs and standing? Are they putting the same amount of weight on both legs when walking? There are really, really fancy treadmills that some clinics have that will tell you as the patient takes a step, are they going through heel strike, foot flat to toe off? And are they applying equal pressure on both legs? Those are limb load monitors. Those are really, really, really high-end devices, but they can tell you a lot, right? Do you think that a patient that has a stroke is going to want a weight bearer through that stroke side? What do you think? Yeah, no, it's just like anything else, right? Total knee replacement patient's going to try avoiding weight bearing on that side. A stroke patient's going to do it to the point that they get neglect. So this is another device that we have. We also have all of us in our care nowadays, or at least most of us, unless you've got like old school phones, all of us carry a phone that have recording capability on it, right? I've set my phone up in the room while I'm working with a patient and recorded the therapy session for them, so that they can go back and when they're sitting in their room later in the day, watch their therapy session to see if they can critique how they did. It can be really useful because they get to see, you know, you may be telling them, okay, Myrtle, sit up straight. You're kind of leaning to that left. And Myrtle's not realizing it. Well, then Myrtle watches the video of it later and she's like, oh my God, you're right. I was leaning to that side. Now I can see it. Right? So anything that you can use, any technology you can use can be great for this. I would probably watch using, VR for stroke patients in the acute care setting. I don't know if that's going to be that great right now, but I mean, there are some VR products coming out for stroke patients to help them improve. NMES and multi-channel FES. I touched on this really briefly at the end of your second semester, just when I was kind of recovering what Dr. O'Neill taught you guys about NMES. So remember, FES is NMES, but not all NMES is FES, right? So FES is functional electronic stimulation. That is neuromuscular electronical stimulation and a functional pattern. right? So if I just slap Russian on my biceps and just have it contracting back and down, 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 that's NMES. If I put that same type of an E-stim on my triceps for reaching for an object, now I'm doing FES. FES is NMES, but not all NMES is FES, right? In order to be called officially FES, it has to be a functional activity. And there are all kinds of techniques out there. The multi-channel, we didn't really get to do a lot of this with E-stim, so maybe I'll try to demonstrate it when we have our lab session before you guys go in clinic. But you can actually do reciprocal NMES. So you could put pads on the bicep and pads on the tricep and have it so that it contracts with the bicep. And then when the bicep shuts off, it contracts with the tricep. So they're working both ways. I would never want to do, so you have single channel, you have, it's not bilateral, it's reciprocal is the term they call for it, or concurrent. Concurrent would mean if you have two channels, they're going to fire at the same time. That could be useful for posture, where I could put a pad on, if I've got a weak left core, I can put pads on my abdomen and pads on my paraspinals and have a concurrent NMES that's causing my patient to sit more upright. But just be aware, what grade on the manual muscle scale does a patient need to have in order for NMES to be effective, at least? Or what should you be thinking? What they should have greater than a what? Well, three's ideal. That'd be perfect, right? But if they have greater than a 1, a 2 is probably the best option. So greater than a 1 means a 2, because there's not a 1 plus, 1 minus, right? There's not trace minus, trace plus. There's just trace. So that 2 range and up, even if it's a 2 minus, we can use NMES. But if we're down in that 1 and that 0 phase, we're not really helping the patient with NMES. We're just kind of torturing them. And we try to stay away from torturing them, even though, PT stands for pain and torture. We try to avoid torturing them if at all costs. So be aware and think about that. You don't want to totally torture the patient if you don't have to. AFO is probably the most common orthotic I work with stroke patients, or I get them, are AFOs, and then usually wrist orthotics as well. And again, I'm not going to order those because I have zero skill in ordering anything upper extremity related. That's when I go, help me people that are specialized in the upper extremity, because I am stupid. Not really that, but I'll get people that are specialized in that. I'm much more on the lower extremity training type activities, right? What does AFO stand for? What does AFO stand for? Ankle foot orthotic. Good, right? Ankle foot orthosis. So now let's change that. What if I have a KAFO? What does that change to? A KAFO. Yes, so now I add knee ankle foot orthosis, right? I can go HKAFO, hip, knee, ankle, foot orthosis. I can go THKAFO, thoracic, hip, knee, ankle orthosis, or foot ankle orthosis, right? All I'm doing is adding different joints when I get through that, right? I've never seen a CTHKAFO where we're going cervical. That's more of a bodysuit. And we haven't quite gotten to Terminator state yet where we're replacing everything with robotics. But ankle foot orthosis are really common because one of the most common problems I see in patients that have, and I'm keeping the chat up just because I'm seeing a lot of replies here. So let me move it out of the way here to the other side, because we already talked about that side. And thank you, Zoom, for changing the way this works. I just want to say that if anyone in Zoom is listening, thank you very much. An exoskeleton, right? We're going to give them an exoskeleton for it. That's or if you're a Transformers fan, we're going to give them the exosuits. If you don't know what an exosuit is, a required watching should be Transformers, the movie from 1986 or 87. It's a fantastic movie. It's one of the few times in the world where kids actually got up and walked out of the movie because they got so mad because their favorite character died. Spoiler. But ankle foot orthosis are really kind of common with patients that have strokes because they lose one motion at the ankle. What motion do you think they lose? One motion in particular, I should say, I guess. Yeah, dorsiflexion. It's really common for them to lose dorsiflexion. Why is that? Well, because the spasticity moves them into plantar flexion. So then that muscle becomes stretch weak. That tibialis anterior becomes really, really stretch weak. So we can give them an AFO that kind of keeps them from going so hard into plantar flexion. There are even AFOs with posterior leaf springs that can snap the foot into plantar flexion or dorsiflexion, depending on what we need. We're going to go through all of these orthotics with me next semester, so don't totally freak out. When we go into 5th semester, we'll go in through all these orthotics. So, when you see solid leaf, modified AFO, posterior leaf AFO, we're going to cover that. That's not going to be part of this semester's tests. Okay. So I can hear Erica right now looking at this going, oh my God, there are so many AFOs there. How am I supposed to know what they mean? We're not there yet. Right. Just understand what an AFO is. And even Kelly can hear her thinking that too. I know she can. Kelly's like going, yep. Okay. I'm almost there, but not quite. AFOs and ankle foot orthosis, be able to understand if we add different joints, what it is, right? If I just have an HKO, all it is a hip knee orthosis, right? Does that make sense? So they're named for the joints they're providing support to. We can control the knee with an AFO set up with the knee, right? We control the knee actually with the ankle as well. If we splint them with the orthotic into 5 degrees of ankle dorsiflexion, when they plant down on that foot, the knee automatically snaps back into extension. And that can be beneficial for standing, right? Or for taking normal gait for a patient that may not have full knee control. And then we can get into those fancy knee orthoses that don't let them fully flex or fully extend. There's all kinds of stuff out there that we can use. There's Bledsoe bracing, there's knee immobilizers, there's ankle immobilizers. There are all kinds of little things we can do. But remember that anytime that we put one of these orthotics on a joint, we're weakening that joint function, right? It's like the idea of an ankle brace. You sprain your ankle and you put an ankle brace on. You don't want to constantly leave that ankle brace on because what you're doing is replacing function with bracing. And so what's going to happen to the musculature of that ankle if you leave that brace on long term? Yeah, it's going to get weak. It's going to atrophy, right? And then you're going to take that brace off and you're going to try to stand on the ankle and it's going to feel like you're standing on blubber or flubber. What was it? Flubber was the movie with Robin Williams, I think. Right? Your ankle's just not going to, okay, it is flubber. See, Jaira knows all the movies. I'm starting to wonder if I should start, maybe this is beneficial for Jaira specifically that we're recording these lectures because he knows all the movies at this point. So he can watch the movies of Mr. McKeever. So be thinking about that, right? Also understand the cheapest AFO you're going to get is kind of a solid AFO, right? All that is basically thermoplastic that's going to hold the ankle in a specific position. These are just like the wheelchair. The more advanced you get, the more expensive the orthosis or the orthotic is going to get. So you have to be thinking about this. You also have to make sure that before you order one of these, the patient actually has coverage on their insurance. We've had patients before come into the hospital where orthotics aren't covered on their insurance, or it's going to require a Herculean leap of argument to get the insurance to cover that orthotic. Oh, well, Millie needs an ankle foot orthosis that costs $39. Well, you need to provide me with 7 doctors' testimony saying that this is going to provide her with benefit. And at that point, we're like, okay, you know what? We're just going to make an orthotic for, I've had that happen, right? Where we're like, okay, you know what? Let's kind of jury rig up a orthotic out of what we have down in the clinic because they're not going to pay for a high-end orthotic. Insurance companies, as much as we hate to say it, insurance companies are there to deny us service, because if they deny us service, less they have to pay out. That means more profit for them. So you have to be kind of thinking about that when you're working with these patients, right? You have to think about their cost to benefit. They may actually have to pay a copay on these. I've had patients where their orthotics have a 75% co-insurance, and the orthotic may be, $7,500, and they have to pay $5,200 of it or something silly like that. Be aware of that. Be a good kind of, what's the word I want to use? An advocate for your patient. But also, like we talked about briefly with traumatic brain injuries, there are assistance programs out there to help these people get orthoses, right? When you start becoming, if you're going to work in this stuff, you're going to work in strokes, you're going to work in neuro, the best thing you can do is get contacts with the companies that make these orthotics. When you're going to, I know that a lot of PTs and PTAs don't take time to go to trade shows or go to conventions. Go to the conventions, get contacts with these people, give them their business card. Yeah, they're probably going to call you 5 times throughout the year to ask you if you need anything. Use that as a trade-off, because eventually down the line, you may need to get million AFO, and you can call up, I wasn't going to say Hanger is not a good example of it, but you can call up John Smith Orthotics Company and say, hey, I've got this lady who would really benefit from an AFO, but her insurance doesn't cover it. Do you guys have anything off the shelf, or that's, last year's model, the year before's model, something like that, that we can get for her that's fairly inexpensive? And a lot of them can do that. I've gotten wheelchairs for patients that were, display order wheelchairs, right? So they have their nice little orthotic store, and the wheelchair has been up on the wall for 2 years or whatever. Well, they're oftentimes going to rotate those out, so we can usually get those at a discount for the patient. So get contacts in the field. It really does help you in the long run. And then also, of course, there's obviously organizations. There's the National Stroke Association and everything else that can kind of help you get funding for some of this. But you're seeing that PT is not just a contained PT field. I hope you see at least in this class here in neuro. Now, maybe if you're doing musculoskeletal, maybe you don't need to have these contacts. But even musculoskeletal, even when I was working outpatient, I still wanted to have some of these contacts because I could get stuff for patients that maybe they couldn't otherwise get. Does it mean that you have to schmooze and you have to talk to people? Yeah, but here's the deal. If I can talk to people, and I hate talking to people, you guys can talk to people too, right? It's not fun. I don't like talking to salespeople. I think they can be rather annoying. But sometimes those salespeople can become your best friend because 60 other people have ignored them. Magic Wheelchair is a great company that I ran into at Comic-Con. And Magic Wheelchair is a company that takes and transforms wheelchairs into fun things for kids. So they'll transform a wheelchair into a Batmobile for kids, or the Invisible Jet from Wonder Woman, or a Tyrannosaurus Rex, or something to that effect. By meeting them, then you can hook those patients up with it. Maybe they've got a kid that won't sit in a wheelchair. Maybe you've got Millie who won't sit in a wheelchair because all wheelchairs are black, and she has some aversion to black, and you've got to find a wheelchair company that's not a black wheelchair. That really, now that I said it, came out way wrong than I was thinking. But anyway, yeah, Michelle was sitting there going, well, where are you going with this, Mr. McKeever? I know you were, right? But now you have a contact, and you know that maybe Colors, which is a big wheelchair company out there that has fancy wheelchairs, maybe they can get us a black sling seat and a red sling seat and a red seat back for this patient. Just that little change, right? Now Millie becomes a bull and she jumps into her wheelchair. I don't know. They're just getting contacts is what I'm saying. And not contacts for your eyes, but also get contacts for your eyes if you need vision compensation. Highly recommend it. All right, so is that it for this lecture? It is for the lecture. All right, so now I want to kind of talk about some different parts. Do we need a break, or do you want to push through and get out early? Because it's currently 11:35. I've probably got about another 20 minutes Do you just want to push through and finish it out and get out a little bit early? Okay, push. I got one push. Do I have any opposed? All right, so we're going to do pusher syndrome then. That's what I wanted to see. All right. So do you guys remember this fun thing when you're talking about the brain? Oh, yay. Well, this is why you learned that long ago in a land far, far away. Was because those areas of the brain are going to tell you, and all this stuff up. So if you look, I don't know how much of you guys have played around with the Blackboard, but Blackboard, I have the lecture set up. And then underneath some of these lectures, I have a folder that says additional material. That additional material has like stuff like this picture, the next picture I'm going to show up. That kind of is additional stuff that you can put into your binder. If you know you're, excuse me, I got the hiccups now. If you know you're going to a hospital and that hospital treats stroke patients, you may want to put some of these in that binder so that you have quick reference guides, right? Again, I highly recommend, and if nothing else, if we're in this day and age where you don't want a physical binder, create a binder on your iPad, right? Where you store some of these files so that you can quickly go back and access them. You know, we have phones nowadays that are storing 512 gig of storage. Throw it on your phone. At least you can zoom in and look at it. Google Drive's great. Yeah, Jaira recommends Google Drive. I like Google Drive, but sometimes you don't have internet. I'm just going to warn you. You know, I've been out at a patient's home out at Lake Las Vegas, and I've needed something, and I bring up my phone, and Sprint's like, nope, we don't service there. Well, it services some areas of it, but in this area, it really didn't have coverage, right? So you've got to be aware of that and have some of the stuff that you use quick reference at your fingertips, right? So we talked about this when we were in anatomy. We covered the different areas of the brain. Now, remember with neuroplasticity, just because we say that the frontal lobe, right, that it has some higher mental functions, it has concentration, planning, judgment, that doesn't mean that's all it does. Neuroplasticity says there are some other links there that do other things as well. So if we get a stroke in the frontal lobe, it doesn't mean we're going to totally lose all of our concentration, because maybe some of the parietal lobe might take over for it because of those latent neural pathways with neuroplasticity, right? But we have our visual cortex, right? Our visual cortex is really closely associated with our association areas of our brain, where our sight plays into our short-term memory, our equilibrium and emotion. Image recognition, image cognition, image perception, right? Motor function area, right? Our motor function area kind of sits right above our ears. We have our Broca's area, which is typically a little bit more on the anterior lateral aspect of the brain, versus our Wernicke's area, which is a little bit more posterior aspect of the brain, right? Our emotional area is typically up there in that front prefrontal cortex, right? That's what provides us with our emotional ability and our ability to just react to the environment. Our olfactory area is probably our closest area to all of our exterior senses. The olfactory area sits right there above that cribriform plate, right? In that little selaturcic area. That's where all those olfactory bulbs come out and go into your nose, which when we have brain injuries, a lot of times one of the first things that you lose is your sense of smell, right? Same idea with a lot of our diseases that affect the brain. A lot of times one of the first things patients lose is their sense of smell, because it's the most exterior kind of cortex or part of the brain. Why do I have this? Well, this can help you when you're thinking about a patient has an anterior cerebral artery stroke. You have to start thinking, even if you're at the boards and you don't remember what are all the problems of an anterior cerebral artery stroke is, because you're not going to remember all of these. It's not going to, you could be the smartest person in the world and you're not going to remember everything that's in the brain. I don't remember everything that's in the brain. I have to review this every time I teach it because I'm getting old. But if you think logically about it, going, okay, anterior cerebral artery, so it's going to the front part of my brain. So that's where my higher level of function is. That's where my emotions are. So I'm going to have problems with that. It at least gives you a going off of to understand when you're talking about stroke, right? So this is a really kind of useful brain map. This, Dr. Johnson, I know had you color one of these, but this is kind of another version of it. Let's look at the circle of Willis here. So This is a really, really, really good card to keep in your binder because this kind of gives you an idea. If you have a stroke here, you have a stroke here, it's going to, what the patient's going to look like, right? If you have an ACA stroke, lower extremity is going to be more affected than upper extremities. We have our anterior communicating artery up here, which is the one that communicates between the two anterior cerebral arteries. They may have problems with, you know, anything that happens with the ACAs, that anterior communicating artery, if they have a problem there, can look like that. We have the penetrating arteries, right? They may have no cortical defect. They may have multiple cortical defects. Our internal carotids, again, major problems. They're going to have, if you have a blood flow cutoff from the carotids, yes, you're going to have contralateral blood flow, but man, that carotid is a good, probably, I don't know the math of it. I'm going to probably say 75% of the blood flow going to the brain. Your vertebral arteries aren't that big. So this kind of goes through it. This is going to talk about what we're going to deal with the circle of Willis. And I want to bring that up next here. So let me stop share real quick and get that other slide, other picture brought up. All right, let me rotate it. And we'll zoom in just a little bit. There we go. All right, so what am I going to make you do other than lots of work? Yay, look at this. Doesn't this look like fun? Can everyone see the circle of Willis picture here? So what you're going to have to do, and there are two ways of completing this. The way I'm going to have you complete this for me is different than the way I'm going to suggest you have it for yourself. I have labeled arteries on the circle of Willis on this picture. What you're going to do for me when I put this up is you're just going to submit a single Word document and you're going to put 1, label the artery, 2, label the artery, just label them down based, you know, so 1, 2, I think I have up to 25 or 26, something like that, maybe 27 arteries on here. You're just going to go through and label them. You're going to have to look for this. It's not all going to be in your rehab book. I'm going to tell you. Now, here's the key thing. I am going to give you the list of arteries. So it's going to be more like a matching activity than it's going to be, okay, I have to go find all these. Does that make sense? So I'm going to give you a list of the arteries that I want labeled, and then I'm going to give you this piece of homework here, and then you're just going to go through and label them based upon what they are. That's, yeah, essentially a word bank. Good way of putting it, Jar. I'm going to give you a word bank, and then you're going to fill those word banks in based upon the number. Each one will only be used once. So I'm not going to have like, it's not like I'm going to have 8 and 8's going to be this artery and then 12 is also going to be this artery. There's going to be 27 answers. So if there are 27 answers and there are 27 blood vessels, that means you need to have each used once, right? What I'm going to highly recommend for you guys is either go into this picture and do it digitally or print off a copy of this picture and handwrite the arteries by each of these. The next question I get asked, Mr. McKeever, do I need to know this for my boards? I wouldn't make you do this busy work if you didn't have to know this. Okay? So that's why I'm making you do this. There have been students that have come back that have gotten a question on their boards where this pops up and it says, number 20 is what artery of the brain on the circle of Willis? Yes, exactly. Jaira's like, oh God, right? So then I get the question, oh my God, do I have to memorize all 26 of these? Probably not. You definitely need to know the big ones like the ACAs, the MCAs, your internal carotids, your pontines, which you guys will see. The pontines are these little fingers back here. Here, I just gave you a free answer, right? Which is your basilar artery. Do you remember which one's your basilar artery? If you had to guess on this slide here, which number is basilar? So remember, basilar is big. Number 10. Yeah, right? The 10 is our big basilar artery. That's the one that's going to sit at the base of the brain. Yeah, you're close, right? And that's why we do this, because it's going to help get association. So the next question I'm going to get is, Mr. McKeever, am I going to have to label this on my final? No. That's why I'm giving you homework for it. So take a deep breath, go, Thank God, right? What you'll have to know for your final is those syndromes I labeled. You know, what's the difference between an MCA versus an ACA, that type of thing for your final stroke. I'm not going to make you label it for your final. That's why I give you busy work for it, right? But it's kind of important to understand, you know, what's the difference between the vertebral artery and what's the difference between, say, the posterior, you know, communicating artery, stuff like that. It helps you understand when you have a stroke, what's happening. Again, we have our 4 feeds. We have our internal carotids and we have our 2 vertebral arteries. This looks like a lot of stuff. It's really not. It's only 20 some items. It won't take you that long, I promise you. Some of you may now, like Erica will be arguing with me for 3 days that I labeled some artery that's wrong, but she's not going to win that argument. Just joking. I have refined my argument skills. I am kidding. You wouldn't argue that. You just come to me and say, hey, I think you might have made a mistake here. I could be wrong, but you might have made a mistake here. So when you're going through it, you're just going to label these arteries. Again, what you want for your assignment for me is just to bring up a Word document. And here's a neat thing. Your answer key or your word bank is going to be a Word document. If you wanted to, you could just go down and put a number beside each of the word bank and then turn that in as your homework. Okay. Just like any other Blackboard assignment, it either needs to be in Word or PDF format. It doesn't accept Google Doc format, right? So if you are one of those people that uses Google Docs as your primary source of, you know, free Office or whatever, right? You can export to a Word document. In it, if you go up to your file and export or file and save as, it'll allow you to save it as a Word document. It'll also allow you to save it as a PDF if you want it, I believe. I think they added that function about 2. So I'm actually going to post this. So today's Monday. I'm going to post this on for you tomorrow. We'll be due a week from Wednesday. I'm going to give you an extra 2 days to complete it. So it'll be due next Wednesday. Again, not a huge thing. And again, this is probably the biggest amount of homework you're going to get from me. You know, I know Dr. Reskin's kind of heavy on homework, so I'm aware of that. And I try to tamp down my homework a little bit and make it as functional as possible. But this is going to be one that is kind of important for you guys to at least learn. Now, does that mean you're always going to remember when you go to your boards, which is the antichoroidal artery? Probably not, right? But it will help you with the major ones. You'll remember those. You'll remember which is the anterior communicating artery, which is the anterior cerebral artery, which is the middle cerebral artery. The little ones I just put in for a little bit of torture for you to make you have to work for it, keep you honest, right? All these little tiny arteries all provide some amount of function to us, and they're all important in the brain. There's really not an artery in the brain that we're like, hey, we don't need that artery. We need them all. That's what keeps us functioning. So this will be an assignment. I'll post it today. It'll be due a week from Wednesday, so you'll get an extra 2 days. And then also the quiz for today will go up. And again, that's not going to be due till the final. All your quizzes now, your first quizzes were due by midterm. Your second set of quizzes will be due by final. I saw a couple of you waited until the very last second to do your quizzes for your midterm. Like literally the midterm started Monday. You were doing your quizzes Monday morning. That doesn't set you up for success for the final. Make sure you try to get some of your quizzes done a little bit in advance so you can at least review the rationale. Oh, I've got to make that remind me. I got to make the midterm accessible. Thank you for reminding me about that, Renee. I know you're going to say it. I will make the midterm answers accessible to you guys. I totally forgot it. Totally slipped my mind to do that. I will do that as soon as we're off this. Literally, like I will go make that change as soon as. The final is going to be 75 questions. I can tell you right off the top of my head. 75 to 80 questions. I think the midterm was 80, if I remember correctly, wasn't it? I think that's what I made it. And you'll have the same thing, 2 bonus questions. But it'll be electronic just like everything else. So that's your one piece of homework for this class. I know it's horrible. It's such a mean thing I'm making you guys do. I'm just a giant meanie head. But too bad. You'll get through it. The only other thing that we're going to probably go through that we'll do together is we're going to go through the spinal cord tracks. When we talk about spinal cord, I think the next lecture is spinal cord injuries, which will be Wednesday. And we're going to go through and label the spinal cord tracts together. It's not going to be homework. We're going to do it together in class. All right. I think that's about it. So are there any questions for today that anyone has? How's that? Was that a lot of material? I mean, and I chunked this down. I really chunked this down. My lecture, yeah, it was quite a bit. When I initially took over this class and I initially wrote my lecture for this, it was something like 168 slides. And afterwards, it was funny because after it, I realized, right, exactly, Jared. I realized why cohort 4 kind of disliked me. I'm like, because I came in and tried to teach everything about, and I'm like, I'm going to teach them everything. I'm going to have 168 slides. And then I was wondering why everyone in the classroom was staring at me with this glossy face that looked like they wanted to kill me, right? I've tamped it down quite a bit. I try to distill it down to what you need to know for your boards. All of those slides, anything on that is valid board questioning. So then it comes, well, Mr. McKeever, what about treating a stroke? How do I treat a stroke? Well, you're going to treat the stroke symptomatically, just like any other neurological condition. If they're having problems with shoulder flexion, we're going to work shoulder flexion. But I've been in my face the whole time today. That's okay, Clarice. I love you just the same. I love all you guys, whether you know it or not. You know, I love my morning classes. I'm probably more awake than you guys most times. But how do I treat a stroke, Mr. McKeever? I've got a stroke that's got this. I've got a stroke that's got that. Well, you look at it and you're going to treat it based upon how your patient presents. If the patient's got a spastic quad, we're going to work on that spastic quad by stretching out that quad. We're going to use some deep pressure. We're going to use some ice and heat maybe intervening, right? We're going to work on loosening up that quad because that quad may be the thing preventing them from standing. If their problem is gait, we're going to work on gait with that patient. And again, before we work on a gait with the patient, they're going to have a gait belt on them. There are some new neat gait belts coming out, which, you know, are a little bit more like restraints than I kind of like, but there's even a gait belt harness that kind of adds a chest harness to it that allows you to control their trunk motion as well. It's a lot more expensive than your average gait belt, but I've seen PTs in stroke clinics use those because it allows them to control the trunk a little bit more than just that gait belt. If I have a patient, let's say I am a right hemisphere stroke, what side of my body is going to be affected? Okay, good. You guys got that. If I am the PT and or PTA working with that patient, what side should I stand on? They're affected or non-affected? Yeah, the left, right? You want to stand on that affected side because if they're going to go down, they're going to go down to that affected side and they're not going to have any protective measures, right? If that arm is flaccid, they can't put that arm out to catch themselves. So just like everything else, you may have to, in strokes, you may have to stand in front of them a little bit instead of behind them because you may need to engage that eye so that they're looking at you, right? But you're going to stand on that affected side. At least in the initial period when you're transferring the patient out, you're going to transfer to the good side, to the non-affected side. Because that way, if they're, you know, you want them to reach for the chair for the transfer, they can actually reach for the arm for the chair for the transfer. But eventually, we're going to move to transferring to that affected side because we want them to be able to do both. If you go in and you're seeing a patient that has a stroke, one of the best things you can ask them is, what side of the bed do you get out of at home? Right? Because what if you're training them to get out of the bed on the right side because that's their good side, and their bed is up against a wall and they can't get out on that right side? Well, you've just taught them something that's completely useless to them going home. Right? You want to make sure that you're working towards their independence at home. Right? If they have stairs, you need to do stairs with them. If they don't have stairs, I still highly recommend doing stairs with them because it's not like we avoid stairs in life, right? Stairs are all over the place. Steps are all over the place. So be aware of those type of things. If this is the first time treating the patient and you're going to get them standing, where should they be? Where should be the best place to stand them for the first time? Yeah, in those parallel bars, right? They are probably the best things in the world for you when you're working with stroke patients. But also make sure if they're the mobile style parallel bars, the ones that are kind of, you can move them around the clinic and stuff like that, make sure they've got the weights on them, or make sure that they're locked down, however they lock down. Some of the parallel bars kind of have, not, I don't want to say locking suction cups, but those things that you kind of lock down, they suck it down to the floor. Some parallel bars, you may have to add 5 or 10 pound cuff weights on the end to keep them stable. Whatever you do something to make them stable. Then a lot of times parallel bars are just mounted to the floor. Great. If they're mounted to the floor, that's one less thing you have to worry about. What height should the parallel bars be in order for functional kind of activities? How high should those parallel bars be? What should you use as a good guideline? Okay, the wrist, what part of the wrist? The styloid process, right? Or the greater troch, depending upon your patient, right? So if you've got somebody that's got, T-Rex arms, you might have to raise it higher than the greater troch. I've got T-Rex arms. Mine don't always, I don't know, I haven't really measured. I don't think they go the whole way down to my greater troch, right? So you may have to raise it higher than the greater troch, but the greater troch, the styloid processes are a great idea for it. It is always better to go a little bit higher than a little bit lower. So if you're like, oh, well, they're kind of between this hole and this hole on my measurement, it's better to raise them up one extra notch where they're kind of able to push up through them and have a greater bend at the elbow. What's the degree at the elbow you want to have again? Do you remember from measurement of assistive devices? Yeah, 20 to 30 degrees. 25 is kind of that ideal sweet spot, but 20 to 30 degrees. 30 degrees works really well if you want them to kind of be pushing heavily up through. When you go out in the field and you're walking around, you're going to see people with 0 degrees because their walker's way low, and that causes them to hunch way over, right? That's why it's a little better to have a little bit higher, because it'll allow them to have upright posture. If you're working with a patient, a mirror is invaluable. I cannot tell you that enough. Mirror therapy, whether it's for, problems with pain with, CRPS, or it's phantom limb syndrome, or just a stroke patient that needs to be able to see what they're doing, it's beneficial. Here's the thing. If you're working mirror therapy, don't stand in front of them and block their mirror. Find a way to kind of get behind them so they can see themselves in the mirror. They don't want to be seeing your butt. All right? Well, maybe some of them do, but for the most part, they want to see themselves in the mirror and actually kind of what they're doing. If you're telling them, okay, look at yourself in the mirror, and Mr. McKeever's blocking Millie, she's like, I can't see myself in the mirror. All I can see is you. That's not beneficial for her, right? So you got to kind of think through these things. If you're working in the parallel bars, primarily, where should you be standing with the patient? Should you be outside or inside the parallel bars with them? Yeah, inside. Don't make the mistake of being outside the parallel bars. You can do it. And maybe once they get a little bit more functional, you might try some of that outside the parallel bars where you're taking some of your support off of them. But if you're outside the parallel bars and they start going down, you're going to have to jump over the parallel bars to get in and save them. Or you're going to torque your back across the parallel bars. Better to be inside the parallel bars when you're working with them. Here's the little magic tip of advice. The wheelchairs will roll inside the parallel bars. I know, it's amazing, right? So you can roll that wheelchair right up to the inside of the parallel bars so that when they stand up, they're in the parallel bars and you don't have to transfer them into the parallel bars, right? It makes it a little easier for the wheelchair to follow too, right? Maybe you need it. So kind of think through those type of objects. When I'm working with stroke patients, I usually have at least one knee immobilizer with me, because I guarantee I use that knee immobilizer quite frequently. We're going to go over that next semester because that's an orthotic. But a knee immobilizer is exactly like it sounds. It's a brace that stops the knee from bending. You've got a patient that's got a 2 out of 5 knee extension strength. You try to get them in standing, 2 out of 5 is not enough to go anti-gravity. It's going to buckle every time. And you can provide support, and you can provide kind of anterior pressure on the knee with your own knee and get them up and standing. And there are techniques that you can do that. but you can get a knee immobilizer on them and get some weight bearing going down through that leg, which can be hugely beneficial. Weight bearing increases overall calcium absorption, which helps prevent osteoporosis, helps prevent fractures. So kind of think through that type of stuff. Make sure they're using their affected side so they're not neglecting it. Involve the family again, right? I've had family members, I'll bring them up into therapy and I'll have them be my tech that's pushing the wheelchair behind the patient, because it gets them involved and it shows them that they're going to need to work a little bit with mom or dad, or they're going to need to work with Uncle Bob or whoever they're working with, right? Get them involved in therapy. Help them understand. Maybe show them how to help Uncle Bob stand up, right? Now, that doesn't mean you turn over your whole therapy session to them, but you show them 3 or 4 times and you have them do it and you guard with them. That could be a really major learning event for these patients. All right, so it's about 12 o'clock. That's about all I have. Are there any questions before I cut you loose? Gotta get loose, foot loose. Adrian says, thank you. Take off your Sunday shoes. Exactly. AJ, stick around. Yeah, I can do that really quick. AJ sent me a private message. I'm just responding to him. All right. Any other questions I can answer for you guys? How you feeling? Tired? Ready to get out of here? All right, I'm going to stop recording.